Okay, so it's done. So, hello, Beer. Hi, Girija. Hi, Dr. Sajata. How's everybody? How had the few weeks been? How's the health? It's good. Lots of ups and downs. I can understand in the commitments in health. For that matter, students, they messaged me that they did not want to miss their stations. So, friends, we are going to do 5 stations today. Hi, Dr. Sabiha. You're silent. So we will do 5 stations today, Dr. Bindu and um, Dr.
Hi,
Bindu.
Assalamu alaikum.
Walaikum assalam. How are you? Not
Fine, Alhamdulillah.
not presenting is that's why silent? No?
No, it's not the reason. Today
Alhamdulillah.
I'm not feeling well even.
Yeah, your voice seems to be is it
Yeah,
is it that seasonal flu and something?
yeah, seasonal.
I can understand. Okay, no problem. Just take rest and just try and absorb the things. No matter, otherwise, it's fine. You can go through the recording as well, Dr. Sabia. So started
Inshallah,
medicines. Started medicines.
inshallah.
Okay.
Inshallah.
Okay, great. So two of the students, they won't be doing today. One is Dalia and other is Dr. Bindu. For them, I've kept 2 stations, which we are going to cover next time in probably in teaching or Eurogyne. I'll add whenever is their availability. So we are going to do 5 stations from postpartum problems today. The important thing is that in postpartum problem, generally it gets overlapped with the labor module. Uh, but again, there's certain tendency of an emergency patient coming in a postpartum problem or some sort of a complication, an angry patient coming in the postpartum problem. So far, the news about the exam is that the November exam, because of the second wave that is going to be online, I would definitely update you guys that how it's going to happen, what were the stations, and gradually we would see. If at all it goes successful, definitely it's going to be another one in February or March, but up till now it's in May. We'll see that how the things go, what are the updates, and accordingly we'll just catch up the pace as well. Okay, so the next 2 stations, the modules we are going to do is the teaching and Eurogyne. I will post the teaching and the Eurogyne both topics earlier so that you've got 3 weeks and you would be preparing for that. Then we can have one after the other 2 weekly these modules as well. Teaching, I know you people are very good at, but still I will give you my template so that there's a good practice going on. All right. So for all the presenters today, Dr. Atia, Dua, Girija, Dr. Sujata, and Fawzia, outside the cubicle, be a quick reader. Please catch the buzzwords. Try and understand what patient wants from you. And structured discussion. Okay, so some babies here. Okay, all right. So what do we have to do together in the module postpartum problem, friends? In postpartum problem, certain topics are very important, which I've discussed in the labor module as well. This is the list. This list is always in combination with certain labor topics and the postpartum topics. Some structured discussions are very important. Patient information leaflets I've discussed earlier in the labor module as well. What do we have to do in the template? We enter into the cubicle and we assess that is the patient in emergency or is she in pain? If yes, please offer the painkillers. Please give her medicine to stop the vomiting. And also, if at all she is having breathlessness, get her oxygen mask and make her a comfortable position. If it's a general case in which the patient is stable, always begin with congratulations on the arrival of your baby because it gives a very good rapport building. Ask her about how she's feeling after delivery. Does she have any complaint, any pain? How about her bleeding? Is she generally well? Any fever, cough? Any problem with the breast, waterworks? How are the bowel movements? Any pain or swelling in the legs? How is the baby latching? And tell me about the previous pregnancies, mode of deliveries, gynecological history regarding contraception plan. Is she generally fit and well? Family history, surgical, drugs, personal, social, mental. If it's an embolism, if it's something like acute problem in a postpartum period, then you all have to avoid these 3 blocks which I've told you, just an emergency. Otherwise, please do ask about that. In examination, you would say that in the presence of a chaperone, I would like to know about your name 4 vitals about the tummy examination, the chest, the breast, the legs, and the vaginal examination to assess the bleeding. According to the cause, we are going to do the management, the team of doctors, if required, like in embolism, like maybe some sort of a sepsis, you need to collaborate with the infection doctor. And if it's some sort of a tear repair, the future consultation has to be with a specialist. So all these things you have to consider in your mind. So MDT, don't forget, if at all it's applicable to the station. And complete the discharge plan. If you are asking her to discharge today, please, she should know that when she has to come. Don't forget the red flag signs, number 1. And don't forget that when does she has to visit the hospital again for the follow-up. All right. So this was regarding the overview of the postpartum for the presenters today, just to do a quick recap so that everything is fresh in their mind. All right. So we had to start with Dr. Atia, who was substituting Dr. Rehma today. So Dr. Atia, have you joined? Walaikum assalam. Thank you very much. Thank you. So luckily today you are the first presenter, yeah? You like being the first, no?
Yeah. So either the first or the last.
Yeah. All right. All right. So how had the things been going? How's the job routine? Busy again? Yeah.
Same busy, too much, because the lockdown has been lifted and the second wave is on the way, but no lockdown again. So
yeah. And I don't know what are they up to, because of the schools and all the things are even getting worse. And one of my party students, she lives in Yorkshire, and she had to appear. The schools were open in Kingdom, and she was like there were few positive students in just 4th grade. And things are very upsetting if the kids and these school age people, because parents, they can get on their own, but if the kids, they get positive, then it becomes really a trouble to handle them, of course. And it is difficult to see kids in this situation. So lots of prayers, hope everything goes fine, Dr. Atya. So what do we have for you today?
probably a simulated patient task.
And what is the station?
I would expect the OC or the post OC or the dyspareunia one.
What is OC?
The obstetric anal sphincter injury.
Okay. OSI. All right.
Or even the headache too. Yeah.
All right. So let's see. How is your guess going? Oh my God, Archana, spot on. Let's see, Dr. Athia. So your 2 minutes, they start now. Let's start the roller coaster. Begin, please.
Next slide.
Yes, please. Dr. Atia, start, please.
Hello, I'm Dr. Atia Rahman, one of the doctors in the emergency today. You are Amanda Paul, 29-year-old.
Yes, doctor, I'm Amanda. I'm having severe headache. I cannot raise up my head even.
Okay, I can see, Amanda, that you are in real pain. The nurse came and did she give you for the pain relief, or you would like me to call her?
No, nothing yet. I've just arrived now.
Okay, I will just ask my nurse to give something for your pain relief, and we will start it now. And once it's your pain is relief, so we can then talk. You would let me know when you are able to talk.
That's okay. I'm better, please.
Okay, thank you. I can see that you have, by the notes which have been given to me, that you are 4th day after your delivery. Okay, so can you tell me more when this pain started and now about the pain and headache?
It's been around 1 day that this pain started. It was yesterday when I had a slight headache, but today in the morning it was worsened. I was sleeping yesterday, and I don't know. Other than that, I was well. But my partner, he noticed that I had few funny turns in the bed. I'm otherwise well, but since yesterday I had a slight headache, but today it's severe in intensity. I cannot simply raise up my head today.
I get it. So, Amanda, is it okay to call Amanda?
That's okay, yeah.
Yeah. Did you had any related things like any nausea, any sickness, any throughout?
Not exactly. Now I feel a little sick, but that's because I think severity of the headache.
Right. And what about your having high fevers, your temperature raised?
No,
Okay.
I'm not having fever.
Right. How about drinking? Are you drinking good?
Drinking. You want to know about like fluids?
The drinking water and fluids, yeah.
I think that was not very well for the last few days because I was trying to adjust with the baby. Yeah, I'm breastfeeding as well, but I don't think that I had been taking adequate fluids.
Right. So, how is the bowel? Did you open your bowel?
Yes, I did. Yeah.
And what about peeing?
Pee is fine. I did in the morning, but yes, I can see that it's a little dark color. That's probably not take much fluid.
Right. How is the baby? Is it a boy or a girl?
Yeah, she's a girl.
Yeah, nice. And did you name it?
Yeah, she's Flora.
It's a nice name, Flora. I know that you cannot even enjoy the company of Flora at the moment because of your headache and that you're the newly mom. So may I know, is this your first delivery?
Yeah, it is.
And any type of such headaches you had before becoming pregnant or during the pregnancy also?
Never.
Okay. Do you have any history of having clots in the leg or lungs for you or your family?
Never.
Okay. And are you aware of your height to weight ratio?
Yeah, that's 26.
Okay, right. And any history of having migraines or some problems like dehydration or high blood pressures before or during pregnancy?
No.
Okay. Anything of concern that you would like to tell me?
Not exactly. I'm just fine otherwise, but it's just the headache which is bothering me.
Right. No swelling in the leg, no problem.
No.
Right. Thank you very much. And in your family, does anybody have this sort of migraines or any problems in the squat of leg or lung?
No.
Right. Okay. Sorry to ask you introduction. Do you smoke or drink alcohol or any street drugs?
Yeah, I do smoke, but it's just like I've not started. I was not doing that in pregnancy, yeah.
Okay, right. And tell me more, how was your delivery? Like it was perfectly a normal vaginal delivery, and how was the recovery after that in these 4 days?
Yeah, that was a very quick delivery. I didn't have any problem at all. The labor was fine as well. No problem with the recovery. First 3 days went really good. But it was just like yesterday, the third day, it started gradually, but today it's worsened.
Right. Thank you very much for this all information. Now, in the presence of the chaperone, with your consent, I would like to examine your, will your examination have already been done, but I would like to recheck your blood pressure, and I would like to check your breathing rate, and I would like to check your heart rate again, and your temperatures. The recording which has been provided by the emergency unit to me shows that the blood pressure for yours is a little bit on the mildly high, whereas the the peeing have been checked for you, which shows some of the ketones. Sometimes the ketones become positive when you are dehydrated. As I can see from your history, as you have told me that you are not able to sleep properly and drink properly. So that may be one of the reasons. Are you with me, Amanda?
I am, but what am I having?
Right. Yeah, probably what we think is that there's due to dehydration, sometime it happens that as you are after the delivery, the blood in the pregnancy and after the delivery become thickened than normal, and there can be chances that sometime a blood clot can move and can log inside your brain and can cause some serious problems that you are having, like severe headache, some high blood pressures. And we will just have to send two of your blood tests to make sure how is your liver functions, how is your kidney functions, how is your some of the blood levels we call coagulation, how is the clotting in our blood. And I will just now involve a team of my doctors, especially my consultant and the brain doctor, to look after you. And we will start with some of the blood thinning agents right away. That would be, it's very important to keep you safe, and it is safe for breastfeeding moms also. I would like to also put a cannula, plastic cannula. I will ask my nurse to put a plastic cannula in your arm, so that in case the need arises, we can give you, or you collapse while talking, so we can just give you some fluids if needed. Are you getting me?
Yeah, I am getting to you 100% sure. I mean, this is something like clot in the brain.
Probably what we suspect with the dehydration and the things is like that, but still, as I have high pressure, but then the urine, I will check the urine again. And if in the urine there shows some protein, then there can be some chances we call high blood pressure related to your pregnancy and delivery, called preeclampsia. For that, we need to have protein. But still, we will rule out after getting the reports of the results of the blood which you are going to send. We will be more confirmatory. At the moment, we will plan accordingly, and we will start the blood thinning agent, and we're gonna give you some of the oral fluids, as you are able to drink some anti-sickness medication, so that you don't feel sick anymore, some pain relievers, so that your pain becomes a strong pain relief. And at the very outset, I would like to inform you that you need to admit at the moment, Amanda. You won't be able to go home. It's very important, because sometimes as you had your funny turns in the home, that can happen again here or anytime again, and that could risk your life. So we would like you to admit. How is the support? Who will be taking care of the baby?
Yeah, that's what I wanted to know. I mean, can I keep baby with me?
There are some midwives nearby. We can keep the nurse in the nearby unit who can come and have your breastfeeding done time to time. Otherwise, if your partner is available, we would like his support or any support that is available with you that can help to take care of the baby alone.
That's okay.
Okay, Amanda?
Yeah, so for
Right.
how long are you going to give these blood thinners?
Probably we will, as soon as the brain doctor will gonna get involved, we call them neurologists, and we may need to run some of the special scans, and like we call them MRV, that is to go through a big machine in which they can check is there a clot in the brain or not. And once that report is ready, then we will be able to exactly tell you for how long. Whereas if it's diagnosed that it's a clot, and probably you will be taking it for a long time, like probably up to 6 months. Whereas it's not needed to continue the injections on daily basis. It can be for after like 2 to 3 weeks, it can be changed into the oral medication for the blood thinning also. That will be discussed further once the diagnosis has been confirmed. Are you getting me? Am I clear?
I get that. That means that in every pregnancy I have a chance for this?
The chances of having second time in the next pregnancy, all the women who become pregnant or have delivery have more. But for you, the risk is more higher, as you already have, if you were diagnosed after the scan, that you have this clot in the brain. So you would be given some blood thinning agent So like start from the next pregnancy as soon as your pregnancy starts, and that it would be very good that once you become pregnant again, you will be given some advice that you must inform the midwife, the booking midwife, so that as soon as you get pregnant, you will be given the blood thinning agent for your whole pregnancy and post delivery for 6 weeks too, or maybe till 3 months according to your situation. And regarding your contraception also, is it okay if I talk now about the contraception?
Yeah, that's okay.
Yeah, so I would like to advise you that not to take anything like specific, which can be the oral drugs that can be hormones, or the injections that are hormones, and the hormones may cause the blood thickening or the blood to clot more. So we will be giving some suitable contraception once you are free and once you are stabilized.
Okay. Thank you, doctor.
Yeah, and I will keep on also advise you. I will write back to your GP about all this, so that once you are over from here, so they can take care of you and the baby. And if you have any such symptoms, we will going to write back to them. At the moment, we will keep you admitted. I'll be right around here. I'll just go inform my consultant, do my necessary work, take your blood, and then we'll arrange the scan and call the neuro doctor. Okay, Amanda?
Yeah, thank you very much, doctor. Thank you.
Yeah, I'll be around. If you have any problem, just tell the nurse to call me back.
Sure, I will. Thank you very much. Thank you.
Thank you.
How did it go, Dr. Athiya? CVT. Yes. Thankfully, you came to the MRV thing. I was waiting for this. And then I said that, are you 100% sure you got the clue that, this is the first investigation you have to do? So you sent the blood investigations, you started the thinner. At that time, it was a little deviating, but a very good thing was that you got the clue that, yes, I want MRV. You understood that, this is something like, this is your topmost differential. It would be a confirmed diagnosis after MRV is done. And I was waiting for that. Very well done. A very good start, a very sound performance as compared to the previous one, Dr. Athiya. Very good. So how did you do?
That's all because of you.
Oh, no, it's all
because you are the one who are providing us so much good feedback, and even you provided us with a whole station template, and it was marvelous from your side.
I'm really grateful. Now, please tell me that anywhere you were feeling difficulty doing the station, or you felt that I'm a little stuck up? Anywhere?
Yeah, as I know the station, so I can do it. Once if I don't know, and then I'll get confused that would I be doing the good go for the preeclampsia thing or not, and like as I have read it, so I know it's for the 6 months to be given. Otherwise, I would have only followed the pulmonary embolism for only 3 months. But due to the template, I did not forget the 6 months.
Very good, very good. All right. So let's begin with the feedback, friends. As compared to the previous presentations, it's a very good presentation, a very composed start, and somewhere in between, rapport building was really good. So to begin with, introduction was all right. Yeah, I've told you earlier as well. I would again like to highlight that point. Dr. Athiya is fine. Avoid taking the second name, not because it would deduct your marks, just because to cut down that habit of speaking extra, right? So I'm Dr. Athiya, one of the doctors covering emergency today, right? Rather than Dr. Athiya Rahman, then it would become your habit. Okay? Dr. Rahman or Dr. Athiya? One word. I mean, I want one name.
Okay.
So then it becomes your habit, and gradually, at times we have to squeeze into the time for the inside the cubicle. Then the extra words we are in habit of, then it becomes a trouble for us. So make a habit of being crisp, okay? So introduction was very good. Emergency, you gave me a pain relief. That was fine. You ensured that I was at the 4th day of post-delivery, so that was okay. You started the information gathering. You asked about the onset. That was good. Sickness, fever, fluids, bowel habits, about my pee. You did ask about Flora. How is she doing? And you did ask about the family history of clots, my BMI. You did ask about the migraine history, the hypertension history. You told me about the topmost differential, as many was ruled out in the history. So it was CVT. A little more explanation I would like to give. I'll just tell you in a bit. And then you immediately sent the blood test. Here, I wanted MRV to be first. In emergency, we are going to do a specialized scan, but nevertheless, you did come to that. You did send blood tests. You started on the blood thinners. You did MDT. And then you came to the special scan of confirmation and you wrote back to GP. So all these points were good points, which I have to appreciate. Coming to a few points which I've written on the right-hand side where we need a little improvement together. Number one, the name, as I've told you. So it's not only for Athiya, please, it's for everyone out there. Please take single name for introduction. Don't make it a habit of like 2 or 3 names because it takes your time. So I'm Dr. Athiya, one of the doctors covering emergency today. So may I confirm your name and age? So she was 29 and you confirmed her name, that she's Amanda. Is it okay to call Amanda? That was good that you did it somewhere in between when you started communicating with Amanda. So that was very natural. It came out very naturally from you. A second thing which you forgot, which I would like to do. What do we do, Dr. Athiya, when in emergency we are giving some drugs, some painkillers? There's one thing which I
allergy, rule out allergy.
Well,
I forgot allergy.
yeah, so neither you confirm later nor at the beginning. So it had to be in the beginning. So in the beginning,
And
I've
also
written down.
confirming age of the patient.
Yeah, you did say that you're 29 years. So now you have to confirm that just before giving the medications, Amanda, so may I confirm that do you have any known allergy? So, you know, at the beginning, the examiner is impressed. Okay, all right, so this candidate is a very sound candidate, a well-practiced candidate. So this is something which you know, so keep practicing the way I've told you that in emergency, you have to speak this thing and then you have to give. So this was first point at the beginning in intro. Then you started with the onset. I was happy about that. When did it start? This was a very good question. However, after this, what should be the second question? Immediately after this, you started asking about the sickness, fever, and fluid, about your drinking, you said, right? So after onset, the most important thing in headache is Dr. Athiya's site. May I know specifically, where is it? Is it on the head side? Is it at the back? Or is it like a band type on your forehead? Does it make sense? Yeah? So the second question I would expect is that you say that it is, where is it? Like the site is important. Onset and site. Don't forget, for headache, site is very, very important because we've got some buzzwords towards the indication. We don't know outside that it's already a CVT, right? Because it's a recall station, so you know, it can be a cluster headache, it can be a tension headache, an occipital region specifically, or it can be a post-dural puncture headache. Am I right? So always ask about the site. Second question, which I expected out of you, was the site. So please add it in your template, the site. Then rather than saying, may I know about your drinking? So generally the drinking word, they use generally like, you know, to drink. So you say that, may I know about your fluid intake? So this is a better way of, you know, just to rephrase, my dear. I could get that what you're asking for because it was ketonuria, but just to rephrase, because if you'll ask about drinking, so maybe they say that, no, I don't take alcohol. Maybe the answer comes like this, right? Or maybe the answer comes like, yes, I do take alcohol. So it's better that you rephrase your question to be in just one go, to be better understandable from the patient's point of view. You say that, Amanda, may I know about your fluid intake after your delivery? How had it been? See, it's an easy, understandable question. So I would have said, no, I'm not taking enough fluids. Right. So this is a little better, just to rephrase, my dear. Then, because site was missed, rather than migraine, before asking migraine, you should say that, may I know specifically, is it half-headed? So when you say half-headed, so basically it is, you're saying that, you know, you're going towards the migraine. Is it half-headed or related with some sickness or vomiting? So this is one question. Because what you have to do in history is in exam, you have to rule out all the differentials. So tension headache, if it's on complete head, your tension headache is ruled out. If it's not in the half head, your migraine is ruled out. Now, you asked about the hypertension. Yes, so preeclampsia, flashing of lights, all that is ruled out. 2 more things which were not asked was, you did ask about my delivery, but specifically, I would like to ask Amanda, may I know, were you given some pain relief in the back? Because I have to rule out post-epidural puncture headache. Okay. So this one question I would specify, because I'm telling examiner that what do I have in mind? I will show you the differentials. I've made a list. So one liner for each differential. Okay. And then because ketones were there, You did ask about the blood pressure raise. I would also like to ask, in the entire pregnancy or ever before, were you ever diagnosed with raised blood sugar levels? Or are you taking any medications? Because diabetic ketoacidosis we have to rule out. So it can come with all these headaches and maybe some sort of features of acidotic. So
Right.
this is one thing which I would like to rule out. Other than that, you said that we have ketones. When you came to the explanation of the chart, observation chart, you said that we've got ketones in the P. So I would avoid saying, the biochemical things for the patient, but yes, what it means to her, I will tell to her the interpretation, because she would be like, sorry, doctor, what are ketones? And you'll be in a mess that how to explain ketones to the patient, right? So what you have to say is that, Amanda, your observation chart shows that your blood pressure is towards the higher side a little, which we are going to observe from this point onwards. Along with that, the examination and the test from your P that reveals that, yes, there is a dehydration element, which we are going to correct from fluids. So element of dehydration has been detected on the P examination, on the investigation. That's it. So ketones don't put yourself into difficulty. See, she doesn't need to know that these are ketones, but yes, what it means to her, yes, she needs to know. All right? Because telling these big words at times, it makes you in a trouble. Then a little slight BBN I would do, Dr. Atia, before telling what CVT is, because let me emphasize on this point that this can be life-threatening. This is not as easy as tension headache. This is not as easy as a migraine, right? A blood clot can be fatal as well. So a little BBN I would appreciate, just like Amanda, I can see that you're here alone today. I would like to talk about something difficult with you. I can understand that this headache, this is for the last one day. From your history and examination, though we are not sure, but the condition we are expecting is that there's a blood clot which is formed in the brain blood vessels leading to the headache. It often causes weakness in the limbs or fits or some funny turns, as you've mentioned. It can occur commonly in the pregnancy last few months and immediate time after the delivery, and as this is the high risk time, it can be more, the occurrence can be more in patients who are dehydrated or who are not moving around, at times in infection as well. But to confirm that, at this very point, we would like to do some specialized head imaging. We call it as MRV. Just to confirm, do you have any contrast allergy? So I won't talk in the history, but now as I'm planning MRV, here I'm going to confirm that to tell examiner that yes, I know I need to take it now. Do you get my point? So this would be my explanation that now we are planning MRV. If it is confirmed, then we are going to send some blood investigations and would you start you on the blood thinners. Now the story would start the way you said initially and came back to the MRV. So with the diagnosis, say that we are going to confirm that with the specialized head imaging, okay? A specialized head imaging. And after that, then we are going to tell all DDs, no, Hashiba, we will just rule out in the history. If everything is clear that it's not, like she's not hypertensive, she's not diabetic, she doesn't have half-headed, she doesn't have fever to rule out meningitis. So that means your job is done. So you're left with your last differential, that is CVT. This is what happened in exam. You're not going to tell all differentials. Why? Because you've taken the history to rule them out. Yeah, that is the reason. Okay. So then you're going to tell about the management plan. So these were few points, my dear, which I've noted, which we are going to improve together. In the suggestion in the end, Dr. Atia, I would also like to tell about you told about the contraception, also like to tell about keeping the BMI towards the healthy side. She's like 1 above, she's 26. All right. So this is one thing which I would like to improve. So let's see. These are the differentials, friends, the CVT, preeclampsia, migraine, post-epidural headache, diabetic ketoacidosis, tension headache, and meningitis. Everything, yes, we are going to observe that. Harshiba, this is what I said. In observation, it is raised. See, secondarily to the pain, blood pressure can also rise. That does not necessarily mean that it is a hypertension. So if you settle the pain, she gets better with her pain, her headache, and the blood pressure gets settled. That means that it was secondarily to the pain. You get my point, Harshiba? Yeah? Yes, okay. So we are going to observe. The only management for blood pressure is that we are going to observe that from this point onwards. Right now, only this, you don't require medication for that. So communication with the patient was very good, Dr. Athiya, today. You had a very good control over your voice. You had a very good rapport building. It was coming out naturally today somehow. So I was very happy on your greeting.
I'm fresh. I have taken a good sleep. I'm fresh. If it's like in the middle, then I get exhausted by listening and
so,
noting down different points.
Yes, I can understand, Dr. Athiya. Respect that. That's why, in the last 15 days, 20 days, I always tell students to do 14 stations in a go with Buddy. And I used to do that, like for 14 stations in a go, because the practice is that
that time the cortisol will work, don't you worry. We are gynecologists, we have immense strength to work in emergency situations. That's not a big deal. We do the 6 hours exam for part 2 in one go. That's not a problem. The problem is that in between to do the classes, then it gets like.
So after 6 to 7 stations, one tends to get a little exhausted. Then you think that the performance is not to the level that like it was in the first few stations. So I always suggest doing exhaustive practices in the last 15-20 days, and definitely will tell you. Yes, we are going to observe for the blood pressure. Yes, Harshiba, we are going to say that we will monitor and we'll talk to you about that if it's persistently raised. At the moment, you don't have to manage that or give antihypertensive. Okay. So I was happy with your communication with the patient. It's undoubtedly 2 by 2 today. In HOPI, I will ask all these questions like, can you tell me more about this headache? Don't forget the site, please, because tells you about lots of things. Is it the first time you had this before? Do you feel any weakness in your legs, hands, any double vision, flashes of the light prior to the headache, any vomiting, any trauma, any loss of consciousness, or you feel that you're confused? What do you think can be the cause of the headache? Were you given pain relief in the back? Don't forget that, because this is one most common headache in the postpartum period. Otherwise, ask about her bleeding is settled, the discharge, the breastfeed, that's okay. So obstetric, gynae, medical, family, surgical, support, that was all fine. Support is also important to rule out the headache. What do we say about the ketones? Harshiba, as I told you, have to say that your urine, the urine test that reveals that it is a state of dehydration for which we are going to give you fluids. That's it. Don't say that ketones are positive. So ketones are positive. She doesn't need to know, but yes, what it means, yes, she needs to know that. Okay. Yes, thank you very much, Dr. Athiya. All right. So patient safety, pain relief was given. Don't forget the allergy. I've deducted your 0.5 from the patient safety because of not ruling out the allergy, because I know you know that. Then you did send the blood complete picture, the kidney test, the liver test, and the clotting profile. That was all right. You came to the proper diagnosis. That was fine. You started the low molecular weight heparin. You did start you did do the MDT, Dr. Athiya, but please, consultant, the brain doctor, and the blood doctor. Don't forget the blood doctor, because hematologist always is there whenever the low molecular weight heparin has to be started. Avoiding COCPs was very good. So these were all good points. So let's begin with the applied clinical knowledge. All possible differentials have to be ruled out in the history. Remember, in the history, this is your first step. Then you're going to say that because I've asked you questions, your history and examination, that tells us that this is the condition which we call it as the CVT, in which the blood clot is formed in the brain blood vessels leading to the headache. And it may often be accompanied by weakness in the limbs or fits as well. So please explain CVT. Immediately with explanation, don't forget that you can't start the treatment. You say that we are going to have a specialized imaging now just to rule out any contrast allergy. And then you start the team of doctors, the blood thinners for 3 to 6 months time, follow-up imaging that the clot is dissolved. Then you can discharge the patient once the clot is dissolved and continue the blood thinners. If she wants the oral medication, that's all right. The blood doctor will talk to her about that. That's baby friendly for the breastfeeding as well. Avoiding the combined pills for the contraception plan. So this would be your immediate plan for this patient. However, you have to tell that for further pregnancy, the blood thinners would be started from the beginning of your pregnancy, and we'll write it very clearly in your discharge notes. So to do the outline, settling the pain was the first thing. Agenda making was good. Narrow down your differential in the history, please. And then come to the topmost differential, or the most important thing which can come in the postpartum, the CVT. Offer her admission. Management of CVT, offer her support. Regarding the support, Dr. Athiya was fine that yes, we can keep the baby here. If the family support is all right, you can keep any family member, or else we can give you the midwife support as well. Future advice about the next pregnancy, starting the blood thinners from the start, please don't forget. And you can give some reading material if she's all right to talk to till the end. If she's still in pain, you can even skip this point as well, because at the moment you're admitting her. So the communication with the patient goes 2 by 2, Dr. Athiya. The information gathering, because of skipping 3 questions, which I've told you about the epidural, tension, headache, diabetes, I will give you 1.5 to be strict. Patient safety, because of skipping allergy, I will give you 1.5. Applied clinical knowledge was 2 by 2. So I'm being strict on these 2 domains because I don't want that these minor mistakes they occur, because I know that you know all these things. All right.
Yeah,
Otherwise, it was
people
a
say
pass.
that if you forget allergy, you're failed in safety.
Exactly. So other things were all done. So about allergy, I don't expect now after so much of practice that you people forget.
Yeah.
Okay. So very good start. Well
We are
done.
not practicing nowadays. No?
I
We
know.
all group members are so much busy. Oh.
I can understand, Dr. Athiya. But the good thing is that at least you people are going like side by side. It's not that the books are closed or you people are not speaking. So that's the good thing. So no problem. Gradually,
That's also the credit goes to you.
no, I will ensure that till exam the things they keep on going sidewise. Already the book pattern I've made from the get through, and also that you people immediately after the exam stations are over, you people start in your mini groups the get through, so that your book sidewise they get completed till December, so that whensoever is the exam, you people are in the best position to take the exam, inshallah. Thank you very much. Thank you for a wonderful start, Group A. And thank you, Dr. Athiya. I hope Dr. Sabia gets well soon earlier, so that she has again the stick in her hand and you people are back to the back to the target. All right. Okay, so friends, let's go to the, thank you, Dr. Athiya. For the second station, so I think we have got Dua here. Hello, Dua, how are you doing?
Hello, Dr. Seda, how are you?
I'm fine, thank you very much. How are you? How's the job going? Tough routine, or is it like a little better?
No, tough routine.
So how frequent are the calls? The same routine, the nights and all going on?
Yes. I have again night duty today.
Okay, all right, I understand. Okay, no problem. We are going to begin with the second station, and 3 more stations. If at all you have to leave, then you can go through the recording, okay? All right. So what do we have for Dua today? Dua did a wonderful station, I remember last time, and it was a top station, yeah? So how is Dua going to do today? So Archana, what do I have for Dua today? Archana is having good guesses today. Okay.
SPT?
What are we going? Yeah?
SPT?
Yeah, it is an SPT, yeah.
Perineal tear?
Oh my God. Girija, how do you people have started reading Sidra Mem's brain, huh? All right, I'll ask you, Girija, what are you getting, huh? Okay, so let's start 2 minutes before Dua opens perineal tear. Go ahead.
Hello?
Dua, go ahead.
Okay, Dr. Seda, next. There is another slide, Dr. Sidhu?
No, that's
Okay. Hello.
start, please.
Hello, I am Dr. Dwyer, one of the doctors in the ward today. Can I confirm your name and age, please?
Yeah, I'm Mary Watson. I'm 31 years, doctor.
How would you like me to call you?
Yeah, you can call me anything. That's not a problem.
Okay, Mary. Mary, as I know that you are here today, you are going to home after your delivery, and unfortunately, you have an extended tear that extended to the muscles that control your defecation. Am I correct?
You people tried your 100% that I cannot go back home, and I do the worst in this delivery. I mean, who was having this experience on me who didn't know that I had to deliver a baby? I had a very small size baby. There was no problem at all. All my labor was going fine. How did they just give a big tear on my back passage?
I really understand your anger and understand your concern. You have all the rights, and whatever you want, we will discuss together. And I will go back to saw your notes to see what exactly happened. And of course, if anything going wrong, we are sure that we will make an incident reporting for that, and we will escalate the matter.
And you still
And
think that
if anything happen
something
wrong,
has not
we will
gone
discuss
wrong?
all of this with you in an honest way. Is it
Dr.
okay for
Gould,
you, Mary?
hold on. You think that something has not gone wrong?
Hello?
Why didn't they give me a small cut?
Hello?
Yeah, why didn't they give me a small cut? Why did they wait for a tear to happen?
Hello?
Yeah, Dua. I can hear you.
Sorry, Dr. Seda, but I couldn't hear anything.
Okay. So why didn't they give me a cut to deliver? Why did they wait to have a tear in the back passage? They should have given me a small cut for the delivery, right?
Actually, Mary, even if we will do a cut, will not protect you to have a tear in the back passage, because actually, according to the evidence, the cut will not protect you from that. And actually, this can happen with anyone. It cannot be expected and cannot be prevented. But actually, of course, we will go back to the notes to see what exactly happened to have something like that. Okay, Mary?
So what it means is that they don't have any method to prevent, and you give tears to every patient here? What you mean, doctor, is that this tear happens to every patient here?
Hello? Hello? My voice is clear? Hello?
100%. Yes, Dua, go ahead. It's clear.
Sorry, I didn't hear again.
Doctor, what you mean is that this tear happens with everyone. So you don't have any method to prevent it.
It's not happen with everyone, Mary. But actually, there is some people, they can get this tear. There is some, of course, there is some risk factor that increase the incidence of that tear. It not happen with everyone. So as I told you, if you don't mind, I will take from you a quick history to know more about your condition, so we can see if there is any risk factor that make you more susceptible to have this tear. Is it okay for you?
But that's okay. Okay, go ahead. Yeah.
Okay. Can you tell me more about your delivery, Mary, please?
Okay, the delivery was perfect. I mean, I just came to the labor suite and I was already 4 centimeters, and it all happened so rapid. I didn't have any problem, but they didn't know that I had to take out the baby, and I had a long tear.
Okay, and how's your pregnancy was going so far? If everything was going good with your pregnancy, you don't have any medical problem, any issue during the pregnancy?
No problem at all.
Okay. And how's your baby right now? Do you give a name to your baby?
I don't know. She's with the baby doctor.
You didn't see the baby till now?
No.
Anybody talk to you about the baby?
I don't know. It just came to them. My partner told me that she's fine, but I've not met her yet.
Okay, don't worry. I will contact also the baby doctor and I will let them to communicate with you so you will know more about your baby. Okay?
Thank you.
Okay. You have any problem in you started to make breast pumping or you have any problem with your breast?
No, I think it's no problem with the breast at the moment.
Okay. Any problem with your water work?
No.
Any problem from opening your bowel?
I've not actually went to the toilet for that.
Okay. You have control for the wind?
Yeah.
Okay, that's good. And now apart from that, do you have any tummy pain, any excessive bleeding or any fever?
No.
Okay. Have you ever been pregnant before apart from this pregnancy?
This was my first pregnancy.
Okay, and generally you are fit and well?
Yeah?
Okay. Any surgery you have before in your tummy or down below?
No.
Okay. Any family history of concern you want to share with me?
No.
Any allergy for any medication?
I don't have.
Okay. Do you know any medicine you are taking right now?
Anybody what?
Hello?
Yeah, what doctor?
Hello?
Yes, what doctor?
Hello?
I can hear you.
Any medicine you are taking right now?
Yeah, they did give me some painkillers. Don't know the names.
Okay, apart from painkiller, any other medicine?
No.
Okay.
ஒரு மீட்டிங்ல கதவு சாத்திட்டு ஞானவழி மட்டும் இன்கேஸ் வராங்கன்னா வந்துட்டு போட்டோம்
Some
இல்லைன்னா
question
வேண்டாம்
about your social life choices. Do
டிஸ்டர்ப்
you
பண்ண
smoke?
வேண்டாம் என்ன சார் முடிகிற வரைக்கும்
Yes, please.
Some question about your social life choices. Do you smoke?
I was not doing that in pregnancy.
Drinking alcohol?
No.
And sorry to ask you, any recreational drugs?
No.
Okay. Any idea about the relationship between your weight and the height?
About what?
The relationship between your weight and the height?
Yeah, that's all right. That's 23.
Okay. Anything else you want to share with me?
No, I just want to know that what the things would be. Like, I'm really exhausted.
I'm really sorry for that, and I understand your concern, Mary. But now we will discuss together what we are going to do for the next few days to make you to feel better, okay? At the beginning, I will reassure you and I will escalate the issue, as I told you. And of course, if anything going wrong, we will discuss that together, okay? But actually, I want to tell you also, whatever who will conduct your delivery is usually all our doctors or midwives here are competent enough, and they didn't go for delivery unless they have a certificate that they are competent to do the delivery and the stitching. Am I clear?
Okay, yeah.
Okay. So as I told you, I will go back to your notes to check if there is any risk factor make you at risk for that. But what we are going to do now to make you feel better, I will give you a painkiller, and also we will give you antibiotic to protect you from any infection. We will give you medication to make your B to be more loose, so you will not have any difficulty in opening your bowel. Am I clear?
How much time I need to take the antibiotic?
Am I clear?
Yeah, how much time I need to take the antibiotic? How much time I need to take the antibiotic?
Hello?
Yes, I can hear you. How much time I need to take the antibiotic?
You will take the antibiotic for 7 days, and you will take this medication to make you lose B for 10 days, and we will see you. We will make a follow-up again for you after discharge from the hospital. We will see you again to check that everything is going fine with you. This will happen after 2 weeks, and then we will make another appointment after 6 weeks to be sure that everything is going fine with you. You can control.
When can I, doctor, when can I resume sex?
Actually, to resume sex, it's better to wait when you are feeling comfortable to do that. If you feel free at any time, no pain, and you feel comfortable, you can start sex. But better to wait after we will see you for the next visit to be sure that everything is going fine.
And when would all these stitches, they would heal?
Actually, this stitch will heal. As usual, any woman after labor, the normal healing, but to be completely, most of the women within 1 year, they will be completely free from any symptoms. About 60 to 80% of the women, after 1 year from this condition, they will be free from any symptoms.
That would take 1 year to heal.
No, for the healing, it will be like any woman after any stitch. The healing will be quickly. Usually, it takes from 3 to 4 weeks to be well healed. But for to be completely free from any symptoms, maximum 60 to 80% for the woman. By 1 year, they will be completely free. They don't have any problem.
Okay. So I just wanted to know, doctor, that would my every pregnancy be now a cesarean section? I'm really scared of delivery.
Actually, it's too early to talk about that, but we will see. As I told you, if you don't have any symptoms, if you can control your B, if you can control your wind, and everything is going fine, and sometimes there's a special scan will be done to check if the muscle that control your B is okay. At that time, you can go for vaginal delivery.
Sorry, the muscle that controls the P, that would be checked through the ultrasound?
No, not routine. If you have any symptoms, we will do for that. But otherwise, if you don't have any problem, no need to check by ultrasound.
Okay.
Okay, so for the next pregnancy, we will talk to you at the beginning to check if you have any problem. If you have any problem in controlling your B or in controlling your wind, or if you have any problem in the scan, if you needed to do that, at that time, it will be better for you to have a cesarean section. But if everything is going fine, you can go for vaginal delivery, okay? And also, we will give you some exercise that you can do, so it can help you to control your B and make the muscle more strong. Am I clear?
Yeah, I get that. Okay. Right. But make sure that this doesn't happen with anybody else. And I would like to see that midwife, once I get better, who just delivered me.
Of course, as I told you, we will investigate in the issue, and I will let the midwife and all the people taking care of you to come and talk to you. And also we will discuss that together in a meeting after investigating in the matter. Okay?
Yeah, that's okay.
Okay. Now, if you want anything, you are welcome to ask me. We will write your medication and your discharge summary, and we will write back to your GB, so they will be aware of your condition. And I will talk to the baby doctor to come and talk to you. Anything else you want to ask about?
That's all right. I'm ready to go home.
Okay, thank you so much. And we are sorry, and we hope you will be fine.
Okay, thank you very much. So lots of internet issue today, huh, Dua? I wanted lots of internet issue today.
Yes, I'm sorry. Really, I'm really sorry.
So I was trying to be very angry, but then you used to say that, okay, I can't listen to you. Then I used to, gather up the anger again. So I wanted to give you tough time in the beginning, but the loss of internet connection made my acting a little less in intensity. Yeah. So
thanks God.
You coped with the situation well. I wanted to make it a trouble station in the beginning. It was a difficult station. She was very angry in exam, and she wanted every clarification as in why it was not done, and few things. I would like to be a little organized. Would definitely tell you that how the things are. See, when you enter into the cubicle and the patient says, Dr. Sabia, that it's okay, you want to call me anything. And you're like, oh my God, you're taken aback from the very beginning. Oh my God, what to say now? What is she doing? You never expect such a response, right? It doesn't make any difference. I mean, you can call me anything. So you're like, be ready for this. He said, oh, okay, all right. So Mary, so don't get taken aback by the loud voice always. They are doing this for a purpose, just to make you confused that yes. So you simply say, I can see that you're angry and it's understandable, Mary. I'm here to talk to you about that. So settling in the beginning was not, I was not very satisfied because you were taken aback by my being angry.
Mother be discharged. Harsha, but they were the baby was fine, not given to her. Today would be given back. So she would be taking baby along with her. The idea was not that she's being discharged because of this reason that the baby is admitted. Baby is fine. All right. So the baby would be being discharged with her. All right. So let's come to the feedback. I would like to improve a little about the angry settlement and few points about the management as well, as I was not very satisfied with the answers of resuming sex and about the ultrasound which you mentioned, and along with that the healing weeks. I mean, the questions which I asked, I have to be a little diplomatic to improve you guys that how we have to answer these questions in the postpartum perineal debrief. Let's see what Dua did good in the station. So she remained composed. I tried my best to shatter her, but she was like, you know, having a control over. She was coming back to that thing again and again to settle me, you know, and that was the good thing, that she didn't lose her composure. Her agenda making was fine, and she tried to initiate the incident report in the beginning to settle me and for the anger. And then it was, she did take the information gathering regarding the baby doctor about opening my bowels, control over the vein, tummy pain, the medical, surgical, family history, allergy, the painkillers, about smoking, alcohol, the BMI support. So again, she said that, sorry that you're in a difficult situation. So all these things were fine. More or less the information gathering went okay. But do ask about the vaginal discharge specifically and any pain or swelling she can feel out there. So these 2-3 things specifically you have to ask in the TIA just to see that she's having sound healing. Now, in the management, it was a little scattered. I would like to do in the general management and the specific management. So we'll tell her that what do you need to do today, and what are those things which are going to be further. I'll just tell those lines stepwise when I'll come to the algorithm. When you made that it was the in agenda, you said that I have understood that you had, what did you say, Dua? You said that you had a tier that is going to the.
Yes, I was confused at the beginning. Yes, I was confused.
What was that word which you said? Because I have to correct that, please. Say that again, that you had a tier which
in the muscle control. I don't remember, but I don't know what I will say at that point. I forget. Okay. I forget.
Guys, go to the recording. There was something like which was about controlling of the bowel, I think. Something like,
yes, something like that.
Yeah. So she said that it was a very long description. You simply have to say that I've gathered that you underwent an instrument delivery and unfortunately there was a tear in the back passage. That's it.
Mm-hmm.
That's it. Okay. Simply, yeah. So exactly. She said controlling defecation. So that was something which was like, for me, it was a very big thing, you know, that, oh my God, what are you saying as a patient? So be very clear. Yes, yes, yes. Harshibai is here. You said that muscles that control defecation. So defecation is a big scientific word which we know, right? Micturition, yes. Defecation. Patient doesn't know what is micturition and what is defecation. Similarly, what you have to say is that, like, you know, the back passage is the easiest thing which covers everything. All right. So you have to say that it has extended to your back passage, and you're sorry about that. So from the beginning, make a very sound agenda so that she doesn't have any trouble. So at that point, I was a little taken aback that, what do you mean, doctor? And immediately I said that episiotomy, why was it not given? The cut was not given. So your answer started, the evidence suggests that it does not help. So never negate what she's saying in anger. That means that you're trying to be defensive. So if I would have been at your place, I would have answered in this manner, Mary, I can understand your anger and I can understand the concern. There are certain steps that should have been taken to avoid this tear in the back passage. As to why they were not taken, like holding the baby, being slow at the time of delivery, doing a warm compression, giving a good one-to-one support. However, the cut at times, the evidence suggests, does not protect, and we cannot predict the tear, but we do have other options as well. Why they were not taken, why this tear, it happened, we have already initiated the incident report and we are looking into the matter. Your statement, which made me further angry, was that we will look into the matter, we will talk to the people who had taken care of you, and if we find something, we will initiate incident report. This point made me angry further, that still you say that you're going to see, I mean, am I lying here? Right. So you have to say we have already, always remember, say that we have already initiated the incident report and we are looking into the matter. Okay? Rather than saying we will look into the matter and see if we have to initiate the incident report. Do you people get the difference? What Dua said, and I caught that as an angry patient. I said, what do you mean? You people do it to everyone. Yeah? So you don't have to say we will see if we have to initiate the incident report. You have to say we have already initiated incident report. Okay? So please be very careful in settling the angry patient, because she's just looking at the words from where she can catch you and be further angry. Okay? So we don't have to give her, further a point of getting angry on any of our statement. So then I will tell you, yes, the management was fine about the antibiotics and always you mentioned. Resuming sex, healing question, I'm just going to tell you, one more thing. Dua, where we do the ultrasound, what is that ultrasound if the symptoms they persist? What is that?
The endoanal, because what I see that we have to do endoanal ultrasound, but this endoanal ultrasound, it will be done if the symptoms is still persisting. So if the patient has any abnormality in the endoanal ultrasound or still symptomatic,
we call it as manometry or endoanal ultrasound as per the Green Top guideline. What did you say to me? And I asked you twice. You said that we are going to do an ultrasound to check for the muscles for P.
I told her if you still have symptoms, at that time we will do the ultrasound for you.
To check?
To check the muscle that control your back passage. At that time I told back passage.
Okay. I asked second, again, go to the recording again. I asked second time that what are you going to check? You said the muscles which control the P. So I was again, So Sujata is,
okay, maybe.
So I asked second time, what are you going to check? You said P. So I was like, it's endoanal ultrasound. So how do you say that? You say this is an ultrasound to check the tone of the muscles in the back passage. This is the description of the endoanal ultrasound. Okay.
But the timing is correct. If she still have symptoms, we will do that.
No. Your recommendation was fine. But it's not to control the P. It is actually for the tone of the muscles of the back. Okay. This is just the improvement which I want to do. All right. So let's see the.
And also, Dr. Seda, I don't know what you mean by when the wound will heal. I don't know what you want at that time.
Yes, I will give you answers for that. Okay. And I will tell you that how you have to. Basically, I asked these questions because the role player asked in exam, and I will tell you everything about that. Okay. So communication with the patient was fine, just despite few things which I want to in the very beginning.
It was your station, Dr. Sadra.
Sorry?
It was your station.
Actually, it was one of my students' station. So I know very clearly what happened actually in this station. It didn't come in my exam. Yeah, it didn't come in my exam. So greeting was fine. Congratulated on arrival of the baby. I would do that in the beginning when I think that if she's fine, if she's very angry the way I was, of course you don't have that liberty to congratulate. This congratulation would come back to you with like maybe some fire words again. So duty of condole I would like to do in the beginning, which was a little less than I expected, and settling anger was a little less than I expected. Be empathetic. You were fine in the end. You offered support. You didn't use any jargon other than this defecation and all. So these have to be avoided. So HOPI was fine regarding the tier. You did ask about all the history. History was okay. Patient safety, duty of control, make it a little more efficient, but you did that. Incident report say we have already initiated. The painkillers, the stool softeners, antibiotics, you did give. Advice for the general hygiene was not given. So I wanted you to do a very good advice for the general hygiene. Sexual activity advice was fine. Okay, could be a little better. Did you offer me pelvic floor muscle exercises?
I remember at the end, I told her I will tell you about some exercise to make the muscle tone. I don't know, let them to stay. I told her or not. Sometimes we forget.
It has to be on the discharge. Yeah, it has to be on the discharge. Okay. So MDT, endoanal ultrasound, if she doesn't get better, if the continued symptoms are there. So a future plan, yes, you're right. The normal delivery, it would be if the symptoms get settled, cesarean section if persist symptoms, assessing the patient's concerns, ideas, addresses. In the end, you could have referred her to launch complaint because she was unhappy. And above all, patient safety cannot be passed if the red flag signs are not mentioned. What you have to mention, I'll just tell you in a bit, okay? So once you enter into the cubicle, and you know, this is something not like a hidden complication. It's not something like she had an operation and now she's having an abdominal swelling and you say that it's a ureteric injury. She knows that it's a tear. So start your talk with the very beginning with this, that yes, I have gathered from your case notes that you underwent an instrumental delivery and there was a tear in the back passage. Am I right? I apologize at the very onset that unfortunately this has occurred, which should not have been here. We have initiated the incident report and we are going to look into the matter as to where things they went wrong. And we are going to communicate that back to you. Would that be okay? So if she is angry and she is a little loud in her voice, please don't get taken aback by this, please. Immediately say, I can see you're angry and it's understandable. I would have been the same. So just be at her side. Because immediately when I said that episiotomy was not given, I would not be defensive and say that it does not have any role in prevention. I would say we have certain steps to prevent the tear to occur. However, as to why they were not taken as to given one-to-one support, doing a warm compression, slow delivery of the head, why is what it was not done? We are already looking into the matter. However, talking about the cut of the delivery, that does not prevent every time. I would talk to you in detail about the management. Would that be okay? Now come about the debriefing and come about the management. Now see, come at the management on discharge. You have to be very sure that in discharge, you touch everything, specifically the general hygiene, because she's prone to have the infection. So you have to say that we are going to encourage you to do some pelvic floor muscle exercises. What they do is they prevent the leakage of the pee and have a good control over your wind. Generally, they get stretched and weakened during the birth, especially after the tear. This happens with many women. So they must recover their strength in order to help you to keep a good control over your bladder in later life too. And I would connect you to the physiotherapist for that, for an easy and it's painless stretching exercises. With this exercise, it is going to be a good flow to the blood flow to the muscles, and it speeds up the healing process as well. So what was her name? She was Mary. Okay. Now, Mary, we are going to give you some painkillers that would help you specifically with some stinging pain, and it would also reduce the swelling. You can also use some cool packs or ice that also reduces the swelling. You can use the salt water bathing if you feel comfortable with that. Along with that, I would suggest that you take some fibers in the diet and lots of water and stool softeners we would also give you. We will give you some medications to prevent the infection to occur in this state for 5 to 7 days. Would that be okay? I would just like to tell you that for the general hygiene dua, which was missed, you have to ensure that this general hygiene thing that she practices, because if you don't touch it, she won't be knowing that, you have to use the plain water to clean your area and wash with after every visit to the toilet, please. You can use toilet paper to pat dry over and around these stitches to help with healing. Try to wear breathable materials or cotton or loose trousers. I hope you understand that. So if you don't tell that, she won't be like sweating and all, because always in tears speak one line regarding general hygiene. Am I clear, Dua?
Yes,
so something like, cleaning with the warm water, breathable materials to wear, all these things, they aid to the healing. Otherwise, this just one line. Touch it for 3-4 seconds, but do touch it, please. Now, regarding her management if symptoms persist, I've told you, if at all after 6 to 8 weeks we see that the symptoms are not improving, we will refer you to the specialized doctor, and the ultrasound to check the tone of the muscles in the back passage would be done, and we'll take things forward from there. So this would be your advice regarding the future management if at all it persists. Now coming to resuming sex and coming to when would it heal. Remember that we cannot give any fixed time for healing, and it varies from patient to patient, so we have to give a diplomatic sentence. So women, generally, she was Mary, women, they report a wide range of perineal pain from mild to severe. The blood supply of these vaginal walls, they are generally very good, and tears, they tend to heal very quickly. But healing, it depends on degree of the damage which has occurred. It depends upon the healing or of the repair and also general health of the women as well. We are going to see you in 2 to 4 weeks time, and we'll be in a better position to guide you how the things are going. Would that be okay? So it actually depends how much was the damage, how it was repaired, and general health, how is she? Because in a diabetic, of course, it's going to be delayed. In a normal, healthy, non-morbid patient, of course, it's going to be a quick one. So it depends upon 3 factors. So we can't say it would be 4 weeks, 6 weeks, 8 weeks, or a month. Okay? We can't
Yes.
tell her anything, but we would say that we are going to see you. So it depends upon how the damage was repaired, how much was the damage, and about the women's general health. It also contributes to the healing. We're going to see you in 2 weeks' time, and we'll tell you that how the things are and how much is the healing. So this is how you have to answer about the healing question. Now coming to the resuming sex. Again, for resuming sex, there's no normal time period which you can give to the patient. Mary cannot be told that it's 2 weeks or 4 weeks. So it's always say, you need to tell her that you need to be ready for things to be different. Mary, I would suggest that take things slowly and be prepared for it to be different. When women, specifically they're breastfeeding and they have a tear and they have a stitch down below, generally the vagina tends to be a little drier. You may use lubricating jelly in the beginning. However, I cannot comment upon the weeks or the months. It is about how you feel comfortable and see that when you're ready to do that. So that's your answer. But always tell one sentence. Always prepare yourself for it to be different. That shows that, okay, it's not that she would be coming back to you again. So I never had dyspareunia, but now I have got such a severe dyspareunia. Initially, because of certain factors of lack of estrogen, breastfeeding, so it is a little dry, so dyspareunia is expected. At times, there's a little narrowing because of stitching and healing as well. So that fibrosis makes it a little difficult as well. So tell her that it may take weeks or months before you feel ready to do that. Please take things slowly and be prepared for it to be a little different. So these would be the lines which would be satisfying her for her questions regarding resuming sex and about healing. If you're sending her back home today, writing back to GP was fine, but do tell her that it is common for women to experience pain and discomfort, Mary, after birth. As the days go by, this should improve. However, if you think that your wound starts to throb, or you develop any fever, or you notice any smelly discharge, please see us without any delay. So if you don't tell these points, your patient's safety goes a little towards the borderline. So she should be knowing that how is she improving? That today pain is less than yesterday. Tomorrow it's less than, days before. Yeah. So you always tell her that it's common that women, they experience pain and discomfort after birth, but as the days are passing, this should improve. Now, this is her standard. She should realize that, things are going towards the improvement. However, if you feel that your wound starts to throb, or you develop a fever, or you notice a smelly odor or a discharge, it is important that you see us without any delay. Would that be okay? So these red flag signs, always remember that you have to mention in the end when a patient is leaving after the perineal repair. Am I clear?
Yes,
Yeah?
absolutely.
Okay, so future birth plan. Yes, you're right. NVT symptoms get settled. A cesarean section if the symptoms persist. So for the outline, introduction, agenda, settle her anger. You settle her anger by apologizing, accepting the mistake, doing the incident report. These are the 3 things. Don't be shaky or don't be miser in using the words of apology. Please openly accept that and openly accept that, yes, it's a mistake. Don't try to be defensive. It would aggravate her anger. And then tell the management of the tear, the general and the specific one, and offer support and the follow-up plan, future advice, and do give her patient information leaflet as well so that she has a better understanding of the follow-up plan. Okay? Clear, everyone? Nadra, Harshiba, yeah? So no jargons as well, right? So patient safety went a little borderline because of not telling the signs. Applied clinical knowledge otherwise was fine. Communication with the patient was, I would give you hats off despite being a little difficult patient. You tried to manage well. Specifically in the end, I was fine with the patient. Information gathering was good. So all these domains, we'll just work upon certain lines which we have to do for this. All right? Very well done. Thank you very much, Dua.
Thank you, Dr. Sid.
A
Thank you.
difficult station doing with us, but I hope everybody learned a lot from this station. So if it
Dr. Rida, I would like to know about that, the first word which you would expect us to say, like when she said, may I confirm your name and age, and she says that whatever you like, how would you like to address, and she says, so what should be our answer to that?
I would absorb that anger. I would say, that's okay, Mary. So I can see that you're angry and I can understand the state. I would have been the same. Can we talk about the situation together and see what we can do from this point onwards? I would like to tell you that we have already initiated the incident report, and I apologize at the very outset that the care you received did not match to the expectation, but we are here to take care of this situation from this point onwards, and we're looking into the matter as to where things they went wrong. We would be open, honest, and transparent about all this happening to you, Mary. Is that okay? So I won't give her a chance to be angry further. I would accept that, yes, you're angry. Now, what is she telling me? Whatever you want to call me, she's telling me that I'm angry. I would say, I can see that you're angry, Mary. Can we talk about this together? Your situation is understandable. I would have been the same. We have already initiated the incident report. So she's giving me a clue that please start your story, start apology. I will pick it from there and start my apology. I can see that you're angry. I would not ignore her gesture.
Oh,
okay, right. It would be so Girija, Dr. Atia has put me in a situation. So I'll take it from that situation and just start. Lines we all know. It's just that you come in a flow. You just speak it one after the other and just tell that we can sit together and talk about that, so that we take your management from this point onwards. I'm here to take care of you in this situation. So all these lines should come like one after the other. She should not get an opportunity from your side to get angry further. Settle the anger there and then. Okay? You all would do that with practice. No problem at all. I'm 100%. You all would be better than Sidra. No problem. Okay? Thank you. All right. So let's go to the station number 3, guys. And we have 4. Okay. So we've got Girija.
Sidra, please.
Yes, my dear.
So just I want to fix the point about the ultrasound. Ultrasound to check the power of the muscle of the back passage or the integrity of the sphincter. Tone.
Yeah, you say that ultrasound to check the tone of the muscles in the back passage.
How can I tell the patient about the manometry?
This is what you have to say, that we see check the tone. Tone is basically an English word.
Oh.
Yeah.
Okay.
Tone of the muscles is like, the strength of the muscles.
And we don't tell her about the integrity of the muscle. We can check
we
it
actually
by
we don't check the integrity. Integrity means that there's some sort of a breach in the muscle, or there's some sort of a breakup in the muscle. This is what we don't check from this. This is what the integrity we check from the examination. What we check from the endoanal ultrasound is that what is the tone of the muscle of the back passage, and in manometry we do the pressure studies. So if it's weakened, so we come to know that yes, some sort of further management is required by the colorectal surgeon. Okay?
Yes, doctor. Thank you very much.
No problem. Thank you. No problem, Archana. Get back with the recording, okay? We are doing 5 stations today. 2 will be done. What I'll do for you guys is that these 5 stations will be done today. So after 3 or 4 weeks, whenever Dr. Bindu and Dalia would do the postpartum stations, 2 remaining postpartum stations, in recording, I'll crop up with this so that you have in one go, okay? I'll do those 2 stations crop and will attach in these so that once you open up later for your revision as well, that will be in one go, okay? All right. So Girija, can we have you here? Good evening from our side. Hello.
Good afternoon.
Okay, good afternoon at your side, yeah? How are you?
Yeah, good.
Okay, that's wonderful to know. So now you tell me, what are you getting today?
Maybe mastitis.
No.
No.
All right. Let's start with Girija. Go ahead.
Okay.
क्यों नहीं पता था? और 5 दिन 8 दिन बाद आप इसको याद करा रहे हैं, उसी दिन वो देख के उसी दिन याद कराना था।
Can I start?
Begin, please.
Hello.
Start, please.
Yeah, hello, I'm Dr. Girija, one of the candidates for the exam, and I'm ready for the structured discussion.
All right. So how are you doing today, Girija?
Yes, good, ma'am.
Okay, that's great to know. So how do you define audit? What do you understand by audit?
Yeah. So audit is a cyclical quality improvement process that basically aims to improve patient care and outcomes by measuring the current practice and then comparing it against explicit criteria that we set, and then implementing changes in order to improve patient care and outcomes.
All right. So why do we do an audit?
So audit is basically to find out how our current practices are, whether we are doing the right things in the right way, and then to see whether it can be compared and it is as per the standards, usually the national guidelines. We would take them as the standards and then compare whether we are doing well or not, and then implement the changes. So that ultimate aim would be to improve the patient care and outcomes.
Okay.
And if there are any mistakes or deficiencies, to correct them.
All right. So can you tell me that for any audit, do we have any prerequisites you need to fulfill?
Yeah, so prerequisites in terms of we would basically need to have an idea how an audit should be done. So we should need to have seen some audits which have been conducted or consult from seniors how an audit needs to be done. And then we would set up a team of individuals who would participate in the audit. And then another important prerequisite would be to take a permission from the ethics committee of the institution, and to select a topic which is important. Important in the sense it should have a significance in patient outcomes, and it should be important to find out whether the practice is good. So choose an important topic, and then also we need to follow the Caldecott principles, where we need to protect the patient confidentiality wherever we take any patient identifying data. And then we would also need to involve all the seniors of our department. And because once we do the audit and we find out the deficiencies, the changes need to be implemented. So all the seniors should be involved so that the changes can be implemented in a right way. And we also need to involve the administrative side as well.
Okay, all right. So what are the steps, if you could elaborate each?
Yeah, so the steps of audit, the first, I would like to describe it in the way of the audit cycle. So the first would be to choose a topic, an important topic, then set up a team to do the audit, then take the permission of the ethics committee, and also do the Caldecott principles, as I earlier said. And then we would need to set up standards and criterias. So these standards usually would be something from the national guidelines. And so we need to set these criterias and standards. Criterias would be the inclusion and the exclusion criterias. Who will be included in the audit, and what are the things we want to measure, and what we would not be including. So the inclusion and exclusion criteria and the standards need to be set.
Okay.
Once we do that, then we need to measure our current practice. So that would be in the form of data collection. So data collection could be retrospective or prospective. Retrospective, usually the cons are that we might miss a few data in retrospective data collection. But we can, whatever we have, we can get through the records. And in prospective data collection, there is a possibility that people might change the behavior once they know that the audit is being done, which is called as the Hawthorne bias. So it could be either a retrospective or a prospective data collection. And then once we do the data collection, we need to analyze the data, and then we would need to present the data. So data analysis would be in the form of qualitative or quantitative. The qualitative as in the numbers, various numbers, like in this particular case, the number of colposcopy referrals happening and how often. And qualitative data would be something like why some referrals were not done in time and what was missed. So once we do that, then we need to present the data. So we would put on all the data in something like an Excel sheet or something like that. And then we need to present the data in the form of bar charts or pie charts. So we will decide how the data would be presented. Once the data collection and the analysis is done, then we would need to have a meeting and discuss the findings of the audit. What went wrong, what was done, what was not done. And the basic aim would be to be hard on the issues, but be soft on individuals. So basically, it's a no blame policy that we would adopt. And then we would discuss the findings and make some recommendations for changes that need to be made. And these recommendations would be discussed in the department meetings or board meetings, multidisciplinary meetings, etc. And then this information would be disseminated to the various individuals involved in the care of the patients in the form of emails, hospital letters, or other things. And then ultimately, we need to set a time frame as to when these changes would be implemented. And then the most important part at the end to close the loop would be to do a re-audit at about around 6 months after this audit to find out whether the changes have been implemented or not. So basically, it is a process audit to see whether the changes have been implemented and whether the outcomes have changed because of the audit.
How do you perform a re-audit?
Yeah, so a re-audit is performed in the same way as we do the initial audit, but only thing is it is done to see whether the changes that we have suggested in the previous audit, whether they have been implemented. So it is done basically for that, and it is usually done after a particular time frame given for implementing the changes.
All right, okay. So what can be a reason of failure of the audit, any audit?
So reasons for failure of audit could be one that the people conducting the audit do not know exactly how to do it, what are the steps involved, and they have not been involved in audits, or they do not take senior opinion at the right time to do how to do it. Second thing is some data could be missed if we do a retrospective data collection. So if we don't have adequate sample size and adequate data to analyze, then maybe the recommendations that we make may not have an impact on the outcome. So that is one of the reasons of failure. And apart from that, I don't know.
Mm-hmm.
And if the audit is not conducted with a full, if the people involved in the audit are not doing it with complete involvement in it, then we may not be analyzing the things. And if we don't use the national guidelines as our standard, then probably the right standards are not set. So then we don't compare it with them. So then it can fail. And
okay, anything you would like to add in any of the questions, please? Yeah.
No, ma'am, that's it.
Okay, thank you very much. Thank you.
Thank
All
you.
right, a wonderful station, Girija. It was difficult. Audit is always difficult, but having a smooth flow
I
in the
have
audit.
lots of words many times.
I can understand, but beautifully done audit. The buzzwords which I wanted you to speak, many of them were spoken. There was a little hesitation in telling about the question number 5. I'll tell you that,
I
that's very
actually
easy.
couldn't think of what to say
Yeah.
for reasons.
No, I'll tell you that when you know the steps of the audit, so the same, take each step and tell why this step would fail. So that would be the reason of failure. Like you, later on, you came to know that maybe the data is not being, the results are not, gathered up in the fine manner, or it's not implemented in the fine. So every step can have a problem, starting from standard, setting standard. So this is the easiest question. You just know the cycle, and this is done. Let me tell you, very good. So lots of praises in the chat box. So friends, it is, don't get scared of audit, please. It is the easiest station provided you know the audit cycle. That's it. Whatsoever comes in exam, It's a colposcopy, it's a lots of perineal tears, it's a shoulder dystocia. Audit is the easiest station. You just need to know the steps of the audit, and everything is related to that. Few things for the examiner I would like to pinpoint. Girija, I'll forget that before I'll go to the SORF station. When I asked you what are the steps of what is the audit cycle? You said that step number one, do it in the form of a cycle, and the step number one is this, and you started explaining. That step number two, then you started explaining. Step number three, you started explaining. So examiner doesn't have this much of attention, like doing lots of, candidates. I would just like to give you a suggestion here that we can, for examiner to make us pass in just like 1 minute attention, we have to make things easy for him, right? So you simply say these are the 5 steps of the audit. Number 1, number 2, number 3, number 4, re-audit, your cycle is complete. Now I will take each and explain.
Okay.
Each step.
Basically, I know the cycle, and now
exactly. Yeah. So this is the audit cycle. Step number 1 is this. Step number 2 is this. Step number 3. You are already passed. But if he has to pay attention, okay, 1 is completed, now 2 would come, now 3, and he has to wait that the cycle, So as an examiner, as I was finding difficult, like, okay, now 4th is touch, okay, I have ticked. So 5th is touch, now I have ticked. So make his life easy. Speak it in a go, please. And then now I'm going to explain, and now I'm going to discuss each one of it. So now it's okay. Now he would be easy. Now you know it, right? So make things easy for him for the scorecard. Okay? So this is just one point which I wanted to tell. Similarly, in failure as well, take first step, tell what can be the shortcoming. Take second step, tell which can be the shortcoming. You get that?
Yes.
So the flow would be good. Only in these 2 questions, I found a little improvement. Rest, you were perfect in all the questions. So audit is the review of the process of the practice of the outcomes against a pre-agreed set of standards and forms part of the quality improvement process. Yes, it is central to improve the quality standards within the healthcare, and it's an important part of maintaining the high standards in the patient safety as well. This is a key pillar of clinical governance and should be carried out by all healthcare staff. The prerequisites are that the organization must enable the conduct of the good quality audit, like appropriate resources to support the process, dedicated time frame for the audit has been provided, and appropriate level of funding is there. Now, if they've given you some special, you can speak 2-3 lines about that special, like shoulder dystocia or colposcopy, but this is the standard answer of prerequisites. Similarly, the organization should have in place the senior clinician, the clinical leads for quality improvement, the clinical audit practitioners who can manage the audit program and the support of the process, and also a program should be aligned to ensure the clinical audit and quality improvement activities that are undertaken as part of the activities. Now I would enumerate the steps first, and then I would explain. So what is the issue or what is the topic for which we need to do the audit? Obtaining or defining the standards, collecting data, comparing the performance with the standards and implement the changes, performing a re-audit, and completing the audit cycle. For each audit cycle, you need to know the buzzwords of each step. That's it. People, they find it difficult because they don't know what do you have to speak in the first. So when it comes to collecting data, it can be prospective, it can be retrospective. You need to know that what is the sampling frame time period, what is the sampling size need to be taken. You make a performer, and there should be a data entry Excel sheets to be made as well. We are going to analyze in the next step, which is going to be a quantitative and a qualitative analysis. Format would be decided prior. That analysis would be put forward on a pie chart and a bar chart, or it would be a proportion. When implementing the change, it would be hard on issues and soft on target, no blame pattern would be taken in the audit. And in the end, it would be completing the loop, doing a re-audit. In re-audit, remember, at least in 6 months' time to ensure that the clinical audit and the quality improvement activities they undertake as a part of the progress to check. The difference between a re-audit and the audit is that it is a comparison of the basal findings which we had previously. So the steps would be again the same. In re-audit, we do not skip any step. The cycle would be the same, but our basal findings would be the previous audit. Now, once we do the re-audit, again, when we do the re-audit, so the second audit would be our basal findings for which we have to compare. So the re-audit is a comparison with the first audit. Cycle would be the same. Remember, generally it is in 6 months' time that you complete the loop and you do a re-audit just to analyze that the things have improved.
Say the reasons of failure, please take each step and tell anything from that, like failure to participate in attitudes to the audit, failure to continue and complete the audit cycle, failure to provide a supportive environment to the audit, lack of resources, especially time management, lack of training in the audit team. At times, cost can play its role and it can be a reason of failure as well. Take each step of the audit cycle and tell about the failure, then your job would be very easy and you will be smooth in your communication. If you don't fumble in your structured discussion, you pinpoint each step correctly, audit is a 90% plus scoring because it's a mathematical structured discussion. It's not something for which you have to, speak or counsel. It is something like which is written step number 1, 2, 3, 4 points in 1, 2, 3, 4, and your job is done. So don't get scared. Any audit in the world comes to you, this is going to be the pet answer. Just add in that topic somewhere in between, like in failure or like in the management or the audit. That's it, 2-3 lines, but the gist of the audit station would remain the same. So beautifully done by Girija. Despite just 2 questions in which I have a little improvement to add, that's it. Otherwise, she did beautifully. All the buzzwords were spoken. Am I clear? Any question about the audit, please, before we move to station number 4?
Thank you, Dr. Sidra.
Thank you very much, Girija. Wonderful station, my dear. There were 3 audit stations, and one was about the colposcopy, one was about the shoulder dystocia, another one was in the book. So my April batch has solved all of them. Have you people solved audit stations, all of you, in these 2 weeks or no? If not, I will send you the
There was one on critical appraisal of shoulder
yeah, that's
dystocia
also
audit.
with that's with me as well. Everybody, you people have solved audit stations? Okay, I'll send that. I'm writing it down. Okay, I'll send the solved audit stations. I checked from my last batch. I gave them homework and they did all the audits. Okay, I'll send in the main group. Okay, so all the audits which were in the exam, 3 audits were there. So in different years, I'll send that. Okay, no problem. All right, so today the competition is going good. Everybody is presenting well. So let's do Dr. Sujata station. Hello, Dr. Sujata. How are you?
Hello, I am fine, Sidra.
Glad to know. Glad to know. Okay, so let's start with the station number 4. Any guess for Dr. Sujata? All right, let's see. What do we have? Please start your station. Yes, Girija.
Hello.
Yes, start please.
Yeah. Hello, I am Dr. Sujata, one of the doctors today. Can I confirm your name and age, please?
Yeah. Hi, doctor. Doctor, I'm Ellie Wilson. I'm 35 years.
Yeah. And how may I call you?
Ellie is all right.
Yeah, Ellie, I see that you have delivered 4 days back and you've come with pain in your right breast. Is that right?
Yeah, exactly. It's swollen. It's big. It's hot, doctor. I cannot simply raise my right arm. It's so painful in the breast.
Did you have some medicines for the pain? Did you
Yeah,
take any?
I just took a painkiller at home before coming here.
Yeah, how are you feeling now, Ellie?
It's not much better, but yes, I'm able to talk to you.
Okay, that's nice. Can you tell me more about how the pain has been progressing? Is it become worse?
Yeah, it has become worse since yesterday.
Okay, and you're not able to feed your baby?
I'm doing that from the left side, but not from the right side. I can't touch it.
Okay. And what else did you try other than the painkillers? Did you try any warm water? Have you tried anything?
No, nothing like that. I don't know. It's my first baby, doctor.
Okay. Can you tell me about the pregnancy? How was the delivery and how was the pregnancy before I come to your breast pain?
Yeah,
Can I ask you questions?
yes, that's fine. Delivery was not a problem. That was a normal delivery, and that was all right. I don't have any problem.
Okay. And did you have any cut down below?
Yeah, they did give a small cut, but that's not a problem. I think that's no aching at all.
You're peeing all right, and
That's
your
fine.
bowel movements are good,
Yeah, that's okay.
and you didn't have any problems in your pregnancy. Your BP, sugars,
No,
everything was fine.
no. Yeah, that's fine.
Okay. What about your? Do you have any allergies, Ellie?
Yeah, I'm allergic to penicillin.
Oh. How did you discover that?
Um, I was ill one day. It was around like 22 years. I was at that time. I had a sore throat, so they gave me some antibiotic. I had a bad reaction to that, so they said that you don't have to take penicillin.
Okay. So
Mhm.
I'll document that.
Thank you.
And what about your height for weight ratio? Are you aware of it?
22.
Okay. Can I ask a few personal questions? Do you smoke?
No, I'm not doing that. I can understand that Flora can have an effect of smoking during breastfeed. I'm not doing that.
Okay, that's good, Ellie. And no, do you take alcohol?
I don't.
Okay. And any recreational drugs?
No,
Okay. And is there, did you have any other surgeries in the past?
I never.
And are you on treatment with a GP for any medical illness?
No, doctor.
Okay. Is there anything else that you would like to share with me? How is your support at home?
Your support is fine. I'm just worried about my baby. I feel that the milk from the left side is not enough. I think that she gets hungry earlier. Moreover, I don't know that I had to feed. I'm just worried. The third thing which I just have in mind is that if you just touch my right breast, it's hard.
Yeah.
I'm just worried that I mean, I hope it's not something like I'm developing a cancer or something. Lots of questions in my mind, doctor.
Yeah, yeah, and not to worry, Ellie. This type of your examination, I would like to do it in the presence of a chaperone.
That's just been done. I mean, the nurse was here. She just did it.
Yeah, so your notes say that your right breast is reddish and tender and swollen. Okay, that is a lot of women get this because your nipple is also inverted. So Flora has not been able to suck from that breast. So what has happened is the milk has got collected in your breast and it has caused the breast tissue to get some inflammation. So with little bit of conservative measures like warm compress and analgesics and wearing loose clothes.
Analgesic, sorry?
Sorry, pain medication. Okay, Ellie, did you understand? It's like paracetamol. Yeah. So with that, you should be able to. The breast should become better, and we will teach you how to bring the nipple out so that Flora can latch on to your breast and drink milk from that breast. Is that right? So I will refer you to the breast nurse who will teach you how to, lactational nurse who will teach you how to bring the nipple out, and with the pain medication and with warm compress, and you have to take plenty of fluids. We will see for one day how you are feeling. I know right now it is all reddish, and you can try some massaging also so that the milk will come out of that breast, and this with the warm compress, the size of the breast also should reduce, and the reddish color also should reduce. If it doesn't reduce after 12 to 24 hours, I'll be starting you on antibiotics. I noted that you have allergy to penicillin, so I'll be giving you erythromycin, which will be safe for Flora and it will not harm you also. Is that right, Ellie?
What do you think I should take?
Yeah, I want you to try all these warm compress and pain medication for 12 hours just to see whether it is improving with that, and the nipple to be everted out. And if it doesn't work, I would give you an antibiotic, that is a medication to reduce any infection.
What antibiotic would you be giving me then?
I'll be giving you erythromycin because you are allergic to penicillin.
I get that right. So you don't want to start it now?
You started only yesterday, no? So can I try for a few hours and see after everting the nipple?
That's all right, but I'm running fever.
Yeah. So then we will start it now. And would you like to? I think I will admit you then and see how you respond to it, so that your pain is also taken care of. And if you respond well with all these measures, then we'd like to send you home. Is that right?
I can't get admitted. I mean, it will be very difficult. Flora is back home.
Yeah, but because you are having severe pain and the breast is also enlarged, so wouldn't it be better that we can see how you respond to it? And Flora also can be admitted with you in the ward, and the midwife will help to take care of Flora. Is that right, Ellie?
Okay, all right.
Is there anything else that you would like to know?
No, I got that, doctor.
Yeah, so kindly take time, and we will admit you, and we will start the medicines to reduce your fever and the inflammation, and I hope you will get well.
Okay, thank you very much, doctor. Thank you. All right, how was it, Dr. Sujata?
Not too good.
You missed 38.2, huh? Did you?
Yeah, I saw it. I saw it, then again I missed it.
I wanted antibiotic to be started now, so I was not getting that, how to make you come to that point, please give me antibiotic, please give me antibiotic. All right, no worries. So anywhere you were feeling a little difficulty doing the station, or it was smooth, were you okay with mastitis? I was happy with your antibiotic getting up that yes, I'm penicillin allergic. So that was a very good point. You didn't miss if I was not penicillin allergic, what would you have chosen for me, Dr. Sujata?
Flucloxacillin.
Very good. Well done. Well done. Right. Yeah, she is, Girija. She otherwise is very motherly. Yeah. All right. So let's begin with the positive points. Introduction was fine. Confirming the name and the age was okay. information gathering was all right later, but first question, Dr. Sujata, was a closed question. So first question
Yeah.
has to be an open
Yes.
question, okay? Okay, then
Yeah.
you came to the documentation of allergy, that was good. BMI checking, smoking, alcohol, medical history, surgical, everything was touched, that was all right. Then you explained what mastitis is. So then it was fine. Warm compression, warm. What did you say about that? Using the warm.
Yeah,
What did you
warm
say? What?
compression and warm showers, I wanted to say. I didn't say
Okay.
that.
Yeah. So pain relief, you said analgesics, otherwise you
Yeah.
wanted to say about the
Yes.
pain relief, the massaging, erythromycin. That was all right. You connected me to the nurse to help me with the feeding. That was very good. So a few things which I would like to say is that in the beginning, I would like to begin with this station, like congratulations. So yes, Ellie, congratulations on arrival of your baby. I can see that you're in distress. You're having a pain in the breast. I'm here to look after you and manage the situation. Is that okay if I ask a few questions to know more about you, and together we can plan a safe and an acceptable, mutually agreed management? So this is how I'm going to start this patient with. I told you that I took a painkiller from home and I'm here so I can talk to you. You said nice. So any patient who is in agony or is in distress or is in pain, avoid the words like good, great, or nice. Nothing is
Okay.
nice today. Yeah, she's not feeling as good. So we can avoid this word saying nice. Yeah.
Okay.
Okay. Yes, Girija, I've yeah, so Girija, I've written this point in points to improve that we have to encourage her from the right side. She has to feed. So if she doesn't feed, it's going to be a vicious circle and it would be like worsening. Okay. So then after that, we have to rephrase one word more, Dr. Sujata, which is discover. So how did you discover that you're allergic? So rather than yeah, you can say that, may I know, how did you happen to know that you have an allergy? Okay,
Sure.
so this is what we
Sure.
can say. Then I said that Flora is back home. I can no get admitted. One way, where did I say the word Flora? You didn't use that. You used it later. So that was, at least you used the word, my baby's name. And when examination is done just now, it's not labor, right? I did tell you guys that in labor, we are going to repeat the examination provided we know that it was a little earlier. But in like local examination has been done, she's just come now. It's okay, we don't have to repeat that. You say that I have been provided with the examination and it says.
Yeah.
Okay, it says, rather than saying now I'm going to examine you again. So it shows a little undermining of your nurse who has done that. So
Sure.
avoid analgesia. We have to say the painkiller. Don't miss the fever, because that's the difference where you have to take the situation from a mastitis infectious and a non-infectious. Okay, so that is where we have to start the antibiotic. So communication with the patient was good. You were organized. This was a case in which she was not very in severe pain. She was talking to you. She had taken an analgesic earlier from home. So yes, you can congratulate on arrival of the baby. And then you can make a good rapport. So first question would be, may I know more about your problem?
Okay.
Your first question was that, may I know, when did it start? Are you breastfeeding? I said no. Are you taking fluids? I mean, don't ask a question which is like yes or no. Give me a little opportunity to tell about my state, right?
Sure.
So ask about, may I know more about your complaints? That's it. So any bleeding, discharge, how about the legs, chest, any waterworks problem? Did you name the baby? Is she latching well? Any problem with the breastfeed? How is the delivery? And then come to the next questions. So first question has to be more open question. May I know more about your breast symptoms? May I know more about your breast complaints? So whatever she wants to tell you, let her know. I was not given that opportunity. I could tell just yes or no to you, yeah? So excluding allergy was a very good point you did in patient safety. Painkiller and antibiotics clarify to the mother always in the postpartum that they are baby friendly. Always tell about the warning signs. Now, please, all of you out there, do you people agree with admission of this patient, or she can be sent back with analgesic and antibiotic? What is the indication of admission here?
Fever and respiratory rate, and she's in, meaning it is reddish. If it doesn't,
you can ask her. You can ask.
Yeah.
See,
the abscess is an indication of admission, remember.
Yeah.
This patient, you can give antibiotic, analgesic, and you can send her back home. The breast abscess, which is, see what happens. First is mastitis. Second is infectious mastitis. And third, if not treated, is breast abscess, in which we have to do incision and drainage. Okay? So we need to know this continuity. This patient can be sent back home because abscess is not developed. You don't have to, even you don't have to give IV. Yeah, you don't have to give intravenous, right? It's an oral antibiotic. So if she can take oral antibiotic now, that is specifically, I asked you, you started her in erythromycin, she can go back home, but you have to tell her the warning signs. High-grade fever, worsening of the breast pain, change in color, or some pus discharge from the nipples.
Sure.
So these are the things you have to tell her, that please see us without any delay, because that means that the things are not getting improved with these antibiotics. So the first thing you have to tell about is discussing the condition, that as she said that Flora was not is not feeding well. So you say this is what happens, that whenever from one breast the feed is not well, the milk doesn't get because of the milk stasis inside the breast, the breast tends to get bigger and swollen. The milk inside, it tends to get infectious. Therefore, we are going to send these investigations of the blood test to rule out any infection, and also milk test for some specific bugs which need to be treated. I would like to tell you that we have got some general management for this plan, in which doing the breastfeed more often to avoid the stasis of the milk inside the breast. I'm going to attach you to the breastfeeding specialist and the specialized midwife for this help, who will guide you for the proper positioning of the breastfeed, specifically in the flat nipples. They tend to be a little more support is required. Would also tell you that the baby is ready for the breastfeeding. They will tell you the signs so that you know that what are the timings for which you have to do the frequent breastfeeding to avoid the stasis of the milk in the breast.
Okay.
So what I need to discuss with you, Ellie, is that it is always suggested that you wear well-fitted inner wears suitable for the breastfeeding. The paracetamol as a pain relief, and certain antibiotics can be given. Because you're allergic to the penicillin, we would suggest taking erythromycin for at least 10 to 14 days time. If things are improving, that's all right. If at all you feel that the fever is not getting subsided, the feeding is not well established, we can admit you for a support. Please see that if fever is persistently rising, it's a swinging fever, you feel that the breast pain is worsening, or there's some abnormal discharge from the nipple, get connected to us without any delay. We are going to admit you to the hospital. We would require to give the same medications to prevent infection through the arm, through a plastic device, we call it as cannula, and along with that, we might have to incorporate and discuss with the surgeon to give a small cut on the breast and drain the infection, if at all the need arises. Am I clear? So now your management is clear. Always tell you, they say that, you know, wearing tight undergarments that gives the less stasis chance. Frequent feeding is very important. She clearly told you that I'm feeding from the left, not from the right. If she's not going to feed from the right, that means that it's going to worsen the situation, no matter how much antibiotics or analgesics you give. Because the leg down is being done, and it's all getting stasis. So we have to avoid that stasis. If because of pain, she cannot have a breastfeeding, at least a breast pump should be used. But basically, the stasis has to be dealt with. Otherwise, it's going to be a vicious cycle.
Okay.
Okay. So these were a few points which had to be added. Yes, Abir, if she cannot take oral antibiotics for some reason, you're going to admit. But generally, the IV antibiotics are for the breast abscess, not for the mastitis. Please remember, if only she comes without fever, you're only going to do this general management, and in specific management like the warm, hot compression and tightly fitted inner wears. These are important, that's it. You will give painkillers. Antibiotics would be with fever, and along with that, you will send the investigation, please. And IV antibiotic would be breast abscess. So there's a difference between a non-infectious mastitis and infectious mastitis with fever and a breast abscess. Am I clear about these 3 situations in the breast? Yeah?
Yes. But what about that inverted nipple? Do we address that issue also?
The breastfeeding specialist, they tell about the positions that how to make the shapes of the nipple. Generally, Dr. Sujata, it should have been done at 36 weeks onwards during the antenatal period. So it's always said that you examine the nipples. If at all you feel that they are not well developed for the feeding, they're not ready for this, you always give there certain artificial nipples which you stick on, and they make the protrusion of that, the nipple, it's there. So it's always, it should be done in the last trimester basically, and you give certain exercises to squeeze and pull up. So if it cannot be done, and if it's not done earlier, at least now you can get her connected to the breastfeeding specialist.
Yes, and with the breast pump. Okay.
Yeah. Yes, Harshaba is right. If she has, you feel that she's unwell, because the abscess patient would generally be a little more unwell like this, like Ellie state. You can do an ultrasound for the collection. Yes, Harshaba, you can do that. Okay. Yes. So otherwise, it's a pus discharge from the nipples as well, and have very high grade fever. Okay, very good, Dr. Sujata. Just few points to get organized, and otherwise it was a good station. Introduction agenda, history taking was fine. Just don't forget the open question. Exclude allergy and explain what causes pain and engorgement of the breast abscess. So stasis, milk stasis, please do highlight and tell your understanding that patient has got it in the right side. Warning signs before you sending her back home, because you were admitting, so you didn't tell, but if you're sending her back home, please tell about the warning signs of the breast abscess and offer her support, follow-up plan, and a future advice. Give her patient information leaflet so that she can learn about this condition, specifically about the baby breastfeeding positions she should be knowing about. All right. Okay, thank you very much. Thank you. Any questions regarding the mastitis? Are you clear about the non-infectious infections and the breast abscess? Clear management plan?
Yes.
Yes? Very good. Thank you very much. Thank you. Okay, so we are here for the last station of the day. And if I'm not wrong, we've got Fawzia here. Hello, Fawzia.
Hello, Dr. Sidra. How are you?
How are you?
Yeah, I'm fine.
Thank you very much. Thank you. So let's do a station with Fawzia. Then I'm going to give you 2 templates of teaching and of the urogyne. Okay. Yes, Fawzia, let's begin.
Yeah, next one. Okay, next. Any more? Hello. I'm Dr. Fawzia, one of the exam candidates. I've read the instructions and I'm ready for the discussion.
All right. So, Fawzia, we are here to discuss about Mrs. Lena David. She's 34 years and she had a forceps delivery. And this is how she is on examination. So can you tell me what are the risk factors for the condition which has occurred?
Yeah, this patient, she's a primary gravida. That in itself is a risk factor. Plus, she had a forceps delivery. So that's another risk factor. Plus, I will be looking into her notes and see how her pregnancy was and how her labor and her delivery was.
Okay. So what is the initial history you would like to take from your patient?
So as regard the history, firstly, I will check I will check since when is the swelling present, and what else, how is the bleeding, and also I will check firstly, I will check her antenatal notes, and I will also check her whether how was her pregnancy. Did she have any complications during the pregnancy, and how was the what was the baby? Did she have any LGA baby? As far as the labor and the delivery is concerned, I will be looking whether she went into a spontaneous labor, and did she have any prolonged first or second stage? Was there any augmentation or any other this thing what was the reason that the forceps was put for her? And during the forceps, did she have any how many attempts were made for the forceps, and what was the tear if it happened, and how was it repaired? Were there any difficulties during the repair of the tear?
All right. How are you going to explain the diagnosis to your patient?
So as far as firstly, I will explain that this is one of the complications that we see that during this instrumental delivery, and this is a collection of blood, and we will, according to the size of this, we will be monitoring her if it requires that if the size increases or there is any changes in her vitals, which we will be monitoring on the chart. Then we will counsel her that we might need to drain this. Otherwise, we will put her on antibiotics and do a conservative management for her.
What is going to be your initial management for your patient?
The initial management of this patient will be firstly exploring the patient with respect to firstly, we will be exploring how the patient is as regard her vitals, whether she's stable or there is an ongoing bleeding which is putting her into shock. If the patient is stable and the size of the hematoma that we see is fine, and there is bleeding is controlled, is not excessive, then we will still put her onto monitoring. We will be sending and we will put her into resuscitation if required in the form of fluids, and we will be sending her investigations with regard to her full blood count and her coagulation profile, and also will be arranging 2 units of blood for her. And and also if required, if the woman has any complaints of not passing urine, I will be after also I will be examining her just to see whether there are any I will be doing a per vaginal examination. I will be doing a full examination, per abdomen examination, just to see that the uterus is contracted or not, and whether there's any full bladder or any other I will be checking the uterine tone and for the bladder. After that, I will be doing a gentle I will be doing a vulval examination to see other than this swelling, is there any other swelling inside also? So I will do a 1 finger gentle per vaginal examination, and we'll see whether there are any other, how far this hematoma is, whether is it inside also or not. And if required, I will also see a per rectal examination that the sutures are not felt there in the per rectum, plus that the swelling is not extending into the rectum.
What would be the definitive management for your patient?
Okay, so as far as the definitive management is concerned, if the woman is settled and she's not bleeding and her vitals are maintained, I will just observe her, and also depending upon the size of the hematoma. If the hematoma is less than 5 centimeters, I will continue to observe her and put her on antibiotics so that this doesn't get infected. will give her a pain relief and also assess her for VTE risk assessment. Will also debrief, will also tell the patient to hydrate herself and give IV fluids if required. If at any point of time the hematoma is increasing, or the woman has her vitals are dropping, or as we can see on the Meo's chart, or the hematoma is increasing in size, or if it becomes more than 5 centimeters, and that's the point that we might consider draining it. With informed consent, we will be taking the woman to the theater and will drain the abscess, drain the hematoma. And then the hematoma will be this hematoma will be drained by giving an incision onto the medial size, so that the scarring is and scoop out all the blood, and to see any visible bleeding sites, if at all. Otherwise, we will take sutures and obliterate the dead space. And after that, we will also we will just after completing it, because the tissue will be friable, so after stitching it and with proper hemostasis, we will be putting a vaginal pack if required, and we'll document this in our notes about the pack when it is to be removed, usually preferably in a daytime. And we'll cover this up with antibiotics, and the catheter will definitely be there for at least 24 hours.
So can you tell me about clinical governance issues to be addressed?
Now, this more importantly, this needs to have an incident reporting, and patient needs to be debriefed about what has happened, and she will be given an honest review. Her notes will be analyzed and told what has happened. And we will be doing the duty of candor, and also we will be keeping her updated once we'll see where were the fallacies and how we are going to follow her up the case, and let her be updated with respect to that. Along with that, there will be a team debrief, and the risk management team will also be looking into this. If it is required, we will be seeing that any if there is any training required, then that will also be done.
Okay, anything you would like to add in any of the question? You've got 5 seconds more.
No. Nothing. Thank you so much for your time.
All right, thank you very much. Thank you. How did the station go? Fawzia?
Oh, sorry, Dr. Sidra, I have nothing written. I'm just looking out of my window and reading, from my mind, and that's why so many mistakes. I'm so sorry. I've forgotten everything.
No, that was very good. I mean, in fact, you covered almost every point. I can understand that she had less risk factors. However, you can speak general risk factors as well, like nulliparity, prolonged second stage of labor, instrumental delivery, baby weighing more, the varicosities, the obesity and all. All right. Mm-hmm. Now, the initial history, always whenever the history question comes, it is always important that you cover all the template. All right. So whether it was a first delivery, or an hours past since delivery, any epidural or pain relief, weight of the baby, hours of which fully dilated, difficult delivery it was, any cut was given down, history about perineal tear, bleeding, and the pain post-delivery, all these questions, they need to be asked. And quickly, the template headings. Like, what are the headings, Fawzia?
Yes.
Like the medical history, the surgical history, the family history. You have to speak it up. All right? Yeah? So what are other histories which you need to know about this patient? Yes. And like after HOPI, what do we ask?
Yeah. So we will ask how was her delivery generally, and how is she coping up with the delivery and everything. And then we'll go to the
Yeah, you simply speak the headings. Okay. Like the medical history, the surgical history, the personal history regarding her personal habits, the support. Get my point? because you have to clarify and you have to complete that history part. Now, explaining the diagnosis, it can happen due to soft tissue injury and collection of the blood in surrounding vagina during delivery. It can cause blood loss and fall in the blood pressure. The risk of infection and continued pain and bleeding, it might recur. In the initial management, the blood investigation, you were very clear in that, the complete blood count, the clotting parameters, electrolytes, kidney function test, the blood for cross-matching has to be done. Informing the consultant obstetrician, the hematologist, anesthetist, the flow nurse, and the informing operation theater team. Guys, I'm having hiccups. Anybody who's remembering me? How do we stop? There was some sort of a myth on that. You put your hand on the filtrum when you have hiccups.
You breathe into a bag. You breathe into a bag and get the carbon dioxide back into your lungs. I mean, or let somebody scream. Yeah. Or let somebody scare you.
You take a deep breath and it takes 7 sips. Oh, Harshiba says 7 sips of water. Continuously, Harshiba, honestly? Okay, 7 sips of water. 7. I mean,
ma'am, just small sips. Small sips.
Okay, 1. And I don't have to take a break in that. 1, 2, 3, 4, 5, 6, 7. Yeah, it would stop.
It sounded 2-3 seconds break.
Let me do that. Okay. I've counted 7 and I've taken 7, Harshiba. I hope it works now. Okay. Without breath, a beer? Oh, you didn't tell me that it has to be without breath. I took a breath in with it. All right. Okay, let's see if it comes again. I'll take 7 more without breath then. Okay. So starting IV fluids, antibiotic, analgesics, and catheter for urinary retention, blood transfusion if required. You were good in this initial management. You did a good management of this initial aspect. Only the history taking, I wanted you to complete the template to name the other parts, and which this is I've told in earlier structured discussions as well. Also, in the vital monitoring, you will find the blood investigations, it was all okay. The definitive management, it depends on the size. In a smaller size, in a hemodynamically stable patient, you have the approach of wait and watch and vital monitoring. If deteriorates, removal of the blood collection in operation theater, securing all the bleeding points under anesthesia and some packing below. And you were very right, you have to ensure that it is removed in like 12 to 24 hours if it all deteriorates. Otherwise, it's only, remember, for small swellings, analgesic, antibiotic, and wait and watch. In large swellings, immediately remove the blood collection. If she's getting hemodynamically unstable as well, you have to shift to the operation theater, monitor that it should not monitor that there's no recurrence, because a bleeder can be there as well. There can be some sort of a cause which can be persistent as well. So always remember that you do a definitive management of a small swellings and a large swelling. So always tell about small being conservative and large being aggressive management. Small only aggressive if the condition is deteriorating and if it's increasing in size. Otherwise, you can do simply a watchful management and monitoring of small swellings. You were right in addressing the clinical governance issue, document, debrief, incident, risk management, and skills and drills. You can speak 1 line for each, but these are the basic points which you have to cover. Yes, Harshiba, so far it worked. I think it's been 1.5 minutes. I didn't have a hiccup. Okay, so that was good. 7 sips worked for me. Any questions regarding a vulval hematoma which you people are not clear about? One thing which I would like to tell you is that nowhere it is distinctive distribution of cutoff of sizes given. Oh, really? Okay, thanks to your husband, huh? Pay my regards. Tell him that it worked on ma'am. Okay, so we don't have any distinct size. Remember, 7 centimeter, 5 centimeter, there can be a cutoff of any point. We don't have any cutoff like below this. We are going to do conservative because there is a combination of hemodynamic vitals. And along with that, no, Girija, I'll tell you, even at 4 centimeter hemodynamically, blood pressure falling, tachycardia rising, you will do aggressive management. So always take the blood pressure along with the hypotension and tachycardia, both in combination. See, a 5 centimeter at presentation at the moment with blood pressure falling and tachycardia may be 7 after a while. So Girija, always remember in exam, Sorry.
Yeah, ma'am. If hemodynamic compromise, then okay. But if it's a 6 centimeter hematoma, suppose, and she is hemodynamically stable, then what do we do?
Then you're going to check that this comes into the domain of a large hematoma.
Okay, then we have to evacuate it, right? So then we consider the 5 centimeter cutoff.
Exactly. What my point is that even less centimeter, but she is hemodynamically unstable, always never say that 5 centimeter it is, blood pressure is falling. You would say in exam that no, we are not going to, you're going to be aggressive on this.
Right.
All right. So otherwise, if she's a stable patient, yes, then you don't see blood pressure and the pulse rate, they're fine. Then it is going to be taking 6 centimeter to the theater for the incision drainage, and the bleeders have to be sutured.
बेटा ये ऐसे रख लो पीछे.
But if it is going
खराब ना हो ये ऐसे ही रहे.
Dr. Atya.
Sorry.
No, it's okay. It's okay. All right. So this is what I wanted to tell in the vulval hematoma. Generally, it doesn't come as an SPT, but even if it comes, that's why I made that part of how are you going to explain to the patient. So please do it like a complication. That is, apology first and treat it aggressively. If it's a less hematoma, smaller one, you can go with the conservative management, but tell her that we are going to observe you from a little more time and see. If everything goes okay and it regresses in size, it would be fine. But if not, we might have to go for the surgical procedure in the operation theater. So there might be some bleeder which has missed. So please apologize, incident report and risk management. That's very important. Okay, so very good, Fawzia. Well done. No, you did not miss much of the points, but I'm sure with these structured discussions, things would be getting better timely.
Yeah.
Now,
Dr. Sitra,
yes, my dear.
Regarding this station, I was very nervous. The second question I wanted to see, Dr. Sitra, please.
Sure. Two more stations are left from this, which we are going to do in the next sittings. Yes, please have a look. This is just the HOPI. This is just the HOPI. After this, I want you to speak. Then I will take the medical history, the surgical history, the family history, the support, the personal history. All headings you have to always speak in the information gathering. Okay.
So first, I will, if they ask me about the initial history, then I will do the personal complaints, whatever she has a complaint.
Yes.
And then about the HOPI, like.
Yes.
And then I will fit in the labor and delivery first, and then the antenatal care. Will it go like this, or I start with ANC and then labor and delivery, and then we go about?
Your labor and delivery would come here because she has just delivered. That would be your HOPI. Yes. Then obstetric history would be your antenatal care. So how is that? I would like to know about any specific event she would like to inform me about the pregnancy, any sort of a morbidity she has. Specifically, I would like to rule out diabetes, hypertension, any bleeding disorder. So all these things, they come into mind when vulval hematoma is there, right?
Okay. And where do we fit, Dr. Sidra? Where, because I didn't do the examination. So where do we fit the examination this one?
It's already done with you. So if it's done, it's okay. If not, you will say that after history, I would like to examine to see the current state and document that examination just to see is for the does it increase in size or it remains the same. That would help me in my management plan.
Okay. Thank you.
All right. Yeah, thank you very much. Thank you. Any other question about vulval hematoma, guys? Done. So we are missing Dr. Bindu and Dalia today. So we'll definitely take their stations in the further modules. Now the plan is, guys, that I've got I don't know still the ticket, but I have to travel to UK for again my locum is on because the flights are open now. So I have to go there for 2 months time or 3 months time again. And now the point would be is I don't know the flight date. It would be around after 3 weeks time. But still what I'll do is that I'll give you the topics of teaching and the Urogyne both. All right. Teaching and Urogyne both. Once I'll give you the teaching and Urogyne, you will prepare teaching for 1.5 weeks and of course Urogyne. So after 3 weeks, I will have the teaching session. Once Dr. Bindu and Dalia, they give me a thumbs up from their side, they're okay. So I'll incorporate their postpartum stations and I'll crop them and put in the same record so that you have your postpartum 7 stations in a go, right? About the teaching station and the Eurogynae, I'll have it in a gap of 1 week because I wanted that before I go there. So, you know, I get 2 weeks time to get settled. So for the newer module, for this module, you'll get 3 weeks, but you have to prepare for 2 weeks. Teaching is sufficient. I know you people are good in teaching. And for that 1 week, you have to start for the next, so that after teaching, we can have frequent 2 sessions, teaching and postpartum. I'll give a break in between. Right? And then I'll give you both the topics of the teaching and postpartum, one after the other. Please prepare in 2 weeks time so that I'll just tell you about the date. So next is going to be on 17th. Yeah. And that is going to be the teaching topics. We will do all the OSATs and everything, which had been very difficult for students. I'll do all those recall stations, which had been a trouble for students in exam. For starting, remember, introduction would be, don't say doctor for yourself. Yeah, I'm Dr. Athiya. No, you're saying, hi, I'm Athiya. If you know the name outside the cubicle, communicate with the name. So, hi, John. How's everything going in the department? I've gathered that you've just joined the department in the last week. I've gathered you want to know about the episiotomy today. So what made you decide that you want to learn episiotomy, John? Yeah, sure. May I know, what do you understand by episiotomy? Have you ever practiced that? All right, so yeah, today we are going to discuss about this would be your agenda. Anywhere you feel that I am quick or you want to ask any question, I would be happy to answer. In the end, I would provide you with the reading material, the strategy tutorials, and the Green Top guidelines. Together we can practice, and then you can take your starting of the teaching station. So this is a fixed starting of your teaching template. This is a fixed ending of your teaching template. Always remember that you have to make somewhere mark that trainee has to perform once. Always ask for the feedback because that contains marks. So how did you find it today's session? I'm going to give you some reading materials, the workshops, and connect to the training workshops. Yeah. So first is on 17, Dr. Athiya. First is going to be on 17. Next, I'm going to inform you. Teaching is going to be on 17th, right? Next, I'm going to inform you after 3 to 4 days. All right.
Okay, and that will be after 3 weeks, or that will be after just 1 week?
No, I'm just going to tell you in just 3 days time, 3 to 4 days time.
Okay. Thank you.
The first is on 17. No, Girija, I will ensure that it's not 9 stations. It would be very difficult. At least, I think 8, it is what we can do. I'll see that if it's 7, at least 8, yeah? Fazia. All right, no problem. Okay, if you want to take a month break, that's all right. We can do that. Yeah, I understand. No, we will do one. We will do one, Harshipa. No need to be quick, my dear. Why should we be so quick when exam date is not there? No need to rush. All right? Yeah. So we won't do that, of course. So making trainee perform, we'll go slow so that things that go sidewise and you can practice your older stations as well. So far exam is in May. If they go in February, even then we are not late. We have got lots of time, yeah? So guiding material, I would suggest a college training workshop, reading guidelines, watch strategy videos, practice on mannequins, offer your support in learning, and then you say thank you. So far 17th is your teaching. So far this is confirmed. Rest, if you want to take a month break or 2 months, that's absolutely okay. I'll discuss with you guys, all right? I'm all available the way you people. Why am I giving 2 templates? So that you people know the topics. All right, so the next 2 topics you people know. So urogynecology basic template, my basic template of urogynecology, it is going to be introduction, agenda. I always used to start that I understand that you're here today because you have some problem with your waterworks. Is that right? Surely in the next few minutes, I will discuss about the complaints and the management options. And can I ask a few questions to know a little more about you? Together, we can come to a safe and acceptable and mutually agreed plan. Now you have to see what has she come for. If her complaints are stress incontinence, this is from my notebook. I've made my questions. Can you tell me more about that? Since how long do you have this problem? Always in stress incontinence. She has come with a stress incontinence, but you have to rule out overactive bladder. So do you feel something coming down? Rule out prolapse. How many times do you need to go to pee in day and night? Do you need to rush to the toilet? Do you pee with an effort or difficulty? Tell me about your drinking habits. How many bottles of water and cups of coffee do you take? Is it affecting the way of life and the way you look at yourself? May I know more about your sexual life? Always do a signposting before that. A few personal questions. May I ask? Right? Signposting before sexual life is very important. Ask about the BMI. Has she tried any treatment and is it effective? If the complaint is about overactive bladder, again, can you tell me more about that? Since how long? How many times do you need to go pee in day or night? Do you need to rush to the toilet? Do you have a leak or do you wet yourself? Do you pee with an effort or difficulty? Tell me about your drinking habits. How many bottles of water, cups of coffee do you take? Do you leak with cough or sneeze? What am I doing now? In overactive bladder, I'm ruling out stress incontinence. Do you people get my point? As a rule, always remember, she presents with SUI, you have to rule out OAB. She comes with OAB, rule out SUI. Am I clear on this point? Always, I'm going to look at information gathering that you have to rule out the mixed incontinence, please. Am I clear? Now, again, do you feel something coming down? So always rule out the prolapse, a sexual life, height to weight ratio. In overactive bladder, you have to confirm that she doesn't have any problem with the catheterization, because there can be a station in which the initial tablets have been used and you have to come to the botulinum toxin. Now, my way of taking prolapse was that it's a long history. So I always used to divide prolapse into bits like onset, signs and symptoms, causes, and then coming causes division into this C3M3HS was my mnemonic. In onset, I used to do for how long do you feel this bulge? Did it increase in size? Does it come out on straining? Is it reducible? After onset in HOPI, I will do signs and symptoms. Does it cause pain? Backache, bleeding, wound, discharge, problem with the waterworks? Do you need to reduce it to pee? Problem with the bowel? Does it cause pain during sex? Is it affecting your quality of life? I will come to causes. C3M3HS is cough, constipation, congenital weakness. M3 is multiparity menopause and mass. HS is heavy weight lifting and past surgery. Treatment taken so far, and the fertility desire. Fertility desire, I will ask in uterine prolapse, please. In walled prolapse, of course, you don't have to ask because she doesn't have a uterus. Generally, she's postmenopausal. So then you have to confirm your obstetric history, the gynae history, the medical history. I will ask about the pacemaker in overactive bladder if I have to give the nerve stimulation. Otherwise, I won't ask this question, okay? In my notebook, this is specifically for the nerve stimulation. The family history, the surgical history, and the drug allergies. In personal history, BMI, please don't forget in urogyne because it has a strong role, and management you have to decrease, ask her to reduce the BMI as well. In examination, always do the general physical. Chest, why? Because the cough can be one of the risk factors for the increase, the prolapse as well. Abdominal examination for the mass and the palpable bladder. Speculum, specifically in the stress urinary incontinence, to use the atrophic vaginal tone as well. So the management always starts with the lifestyle modification first, and then according to the cause. Okay, is it stress urinary incontinence? Is it diffuse overactivity? Is it pelvic organ prolapse? And then if she has any concerns, and then follow up. Students, they generally have a difficulty in completing the urogyne history in 3 to 4 minutes time because it's a long history. So that's why I've given the complete template so that you just cram it up and practice it so that it goes well. All right. So this brings to the end of the session today. Just give me your input if you people want a break, that's all right. I will just open up the calendar again to confirm you guys that it is 25th today. Next, we have planned for Saturday because we do Friday and Saturday, okay? So we are skipping 3rd, we are skipping 10th, and we are doing 17th October, okay? Right, 17th October is going to be teaching. Am I clear? Clear, everyone? Yes,
yes, yes.
Thank you.
And then there
Dr.
will be
Sidha,
no second session in this October.
You people don't want? You people want a break of again 3 weeks? That's okay. We can take a 3 weeks break again for urogyne.
Oh, you tell us what you are doing, so I have to plan my vacation.
The thing is, Dr. Atiya, what we are thinking, because now, Dr. Sidra, the thing is that in England right now, they are planning another lockdown. And so, yeah, so the things are very strange now because we are, where I live, it is almost in lockdown. So what we are suspecting is that the exam, which we were thinking before will be in February, will not be there in any case scenario, because once they close in October, they will not open before Christmas and New Year. So what we were thinking, Dr. Siddha, really, because my kids, they go to school, and even Girija and Jyoti was also saying the same, that what we are thinking, if we can stop here, because we really need your supervision and to present in front of you. We don't want to miss that chance. And since
what we can do is that we can give a 3 weeks break. So 7, how many stations or sessions modules are left?
5, I think. We 5 more sessions are left. Yeah, so but we have a good break. Dr. Sidra, but we have a good break now between Ops and Gynae. What we were thinking, and even the group B and my group was ready. I asked them all.
Yeah.
So they were thinking that if we can prepare, because we have a backlog of our stations of Ops which we haven't prepared yet.
Okay. So what you want is that we take at least after teaching, after 17th, what we can do is that you people take 1.5 months and revise this. We will be in touch in the mini groups. Right?
Yeah.
So that you revise from the beginning. But I don't want that you people just close the books then, huh?
No.
We will take 1.5 months and you'll just revise from the start, and then I'll give you after 1.5 months, we'll do just again one, so that we don't have, you know, a problem in between that, you know, we are just not practicing. Okay, fine.
Yes.
So in
so Dr. Siddha, so in between we can solve the books at least, so we can start our session maybe by January. It will be okay.
Yeah, that's
this
right.
Is a plan.
What you're saying. Yeah, in January, because then we can present to you, Dr. Sidra. We want to present to you because then we have that feel of exam. You know, we are really anxious to present. Otherwise,
I know. Okay, relax. Let me sort it out from other mini groups as well. For now, what we can do is
take your 1-to-1 sessions more again in January onwards.
That's okay. I understand. I'm all available for all of you. What we can do is that right now at the moment, 17th is teaching. And after that, I'll take input from everyone. And then we can, maximum, I'll give you like 1.5 month break. But for that, you can complete from the first recording and you can revise everything. So these modules, they get prepared. Okay,
yes.
These modules get prepared,
so
and then what we can do is that 3 weekly we can have like 1, so that you people are not just forgotten. You people have a little, you know, pressure on your mind that at least we are doing something rather than stopping. But I understand your point, Fawzia. We'll make it slow. Okay, no problem. Okay, so for now, 17th is the teaching session, and afterwards I'm going to clarify to all of you. 17 teaching topics I'll just be posting in a bit so that you people can start. All right. Okay. So take very good care of yourself. Have a lovely day. Please take care of your health as well. And specifically out there, take good care, because the second wave, definitely we have heard that, but I hope everything goes fine. And remember in prayers as well. So I would be uploading the recording just in 4 to 5 hours, hopefully, when it would be received. Thank you very much. I love you all. Take very good care of yourself. Thank you to all the presenters for the wonderful presentation today. Thank you. Bye-bye from my side. Good night. Bye-bye. Thank you.